We're live, Dr. Perlman. We don't have a sound. You can begin.
Okay. Well, I'd like to welcome everybody to the 192nd meeting of the Vaccines and Related Biological Products Advisory Committee meeting. I want to welcome the members of the committees, the ad hoc members, and the public viewing remotely, as well as members of the agencies who are here. So we think this is going to be a really interesting meeting, and we hope to have participation by everyone. And I just want to remind the committee members and participants to use your raise a hand feature and turn on your question when you have, and turn on your camera when you have a question or comment to make. And then as the chairperson, I will call upon you in the order of receiving the hands raised, as in order of the hands being raised. So with that, I'd like to now turn the meeting over to Cicely Reese for committee introductions and reading the conflict of interest statement.
Thank you, Dr. Perlman. I am Cicely Reese and serve as the designated federal officer for today's meeting of the Vaccines and Related Biological Products Advisory Committee. On behalf of the FDA, the Center for Biologics Evaluation and Research, and the committee, I am pleased to welcome everyone to today's virtual meeting. Before we begin, I would like to thank the many individuals and teams who helped make today's meeting possible. I extend appreciation to center leadership, the Office of Vaccines Research and Review, led by Dr. Kaslow, and particularly Carol Weiss, Jerry Weir, Ting Wong, and Dr. Sudhakar Agnihothram for their leadership, preparation, and support. I also want to thank Dr. Rachel Bressler and the Advisory Committee Oversight and Management staff, as well as our colleagues in Disclosure Ethics, Web Hosting, and the Virtual Conference Center and Audiovisual teams. Their work behind the scenes is essential to ensure these meetings are conducted smoothly, transparently, and in the support of FDA's public health mission. We are also grateful to today's presenters from FDA, CDC, Technical Advisory Group on COVID-19 Vaccine Composition, and U.S. COVID-19 vaccine manufacturers for their time and the important information they will provide to support the committee's discussion. FDA also extends sincere appreciation to the committee members for their time, expertise, and independent judgment they bring to this important work. And finally, I would like to thank our acting chair, Dr. Stanley Perlman, for leading today's meeting and for his continued service to the committee. To everyone who contributed to bringing this meeting forward, thank you. Next slide, please. Please direct press or media questions for today's meeting to HHS Press Room at hhs.gov/press-room/index.html or dial 202-690-6343. The transcriptionists for today's meeting are Ms. Virginia Diaz and Ms. Myra Angulo. Next slide, please. We will begin today's meeting by taking a formal roll call for the committee members and temporary members. When I call your name, please turn on your camera, unmute, and introduce yourself by stating your first and last name, organization, expertise, or role. And when finished, you may turn your camera off so we may proceed to the next person. We'll start with the acting chairperson, Dr. Stanley Perlman.
Hi, thank you. I am Dr. Stanley Perlman. I am a pediatric infectious disease specialist at the University of Iowa, and my expertise is in coronaviruses.
Thank you. We'll move to Dr. Berger.
Hi, I'm Adam Berger. I'm the director of the Division of Clinical and Healthcare Research Policy at the National Institutes of Health. I'm a geneticist with additional training in immunology. Thank you.
Thank you. We'll move to Dr. Durbin.
Hello, I'm Dr. Anna Durbin. I'm director of the Center for Immunization Research at Johns Hopkins School of Public Health. I'm an adult infectious disease physician specializing in phase 1 and 2 clinical vaccine studies, particularly flavivirus vaccines. Thank you.
Thank you, Dr. Durbin. We'll now have Dr. Folarami.
Morning. My name is Timi Folarami, and I'm the Vice President for U.S. Vaccines Medical Affairs at GSK. And my background is public health and infectious disease.
Thank you, and we'll move to Dr. Gans.
Hi, Dr. Haley Gans, pediatric infectious disease at Stanford University, and my area of expertise is vaccine immunology. Thank you.
Thank you so much, and we'll hear from Dr. Munoz.
Yes, good morning.
So, Dr. Munoz, we're having some audio difficulties. We'll probably come back to them. We're going to work on that. So, Gideon, if we can mute her and move on to Dr. Omer, and we'll come back to her once we troubleshoot.
Hi, I'm Saad Omer. I'm the Dean of the O'Donnell School of Public Health at UT.
Thank you, Dr. Omer. Dr. Omer, were you finished?
Yeah, I wasn't finished, but I don't know when I got muted.
You can start again. That's fine.
Sure. I'm Saad Omer. I'm the Dean of the O'Donnell School of Public Health at UT Southwestern, and my focus is on epidemiology and interdisciplinary vaccinology.
Thank you. And we'll hear from Dr. El Sali.
Good morning. My name is Hannah Sahli. I am an adult infectious diseases physician at Baylor College of Medicine. My expertise is in clinical vaccine development with a focus on respiratory viral diseases.
Thank you. And we'll hear next from Dr. Patel.
Good morning. I'm Manisha Patel. I'm the Chief Medical Officer in the National Center for Immunizations and Respiratory Diseases at CDC. I'm a pediatric infectious diseases physician with specific expertise in vaccine preventable diseases. Thank you.
Thank you. And we'll now hear from Dr. Rubin.
Hi, I'm Eric Rubin. I'm an adult infectious disease physician at the Brigham, at Harvard, and the New England Journal of Medicine.
Thank you, Dr. Rubin. Regarding Dr. Munoz, we'll come back to her at the break, after the break, and we'll troubleshoot. At this time, I will now read the conflict of interest statement for the meeting. The FDA is convening today's meeting of the Vaccines and Related Biological Products Advisory Committee, or VRBPAC, under the Federal Advisory Committee Act of 1972. The VRBPAC will meet in open session to discuss and make recommendations on the selection of the 2026-2027 formula for COVID-19 vaccines for use in the United States. With the exception of the industry representative, the members of the committee are either special or regular government employees and are subject to federal conflict of interest laws and regulations. Accordingly, FDA has reviewed the financial interests of the committee members for compliance with federal ethics and conflict of interest laws. The agency has screened the members for potential financial conflicts of interest related to today's meeting agenda, both their own interests and those that are imputed to them, including those of their spouses, minor children, and employers. Based on the agenda for today's meeting and all financial interests reported by the committee members, FDA has determined that all members of this advisory committee are in compliance with federal ethics and conflict of interest laws. And as a result, no conflict of interest waivers under 18 U.S.C. 208 have been issued in connection with this meeting. Dr. Timi Folarami of GSK is participating in this meeting as a non-voting industry representative acting on behalf of regulated industry. Consistent with current agency policy, FDA is only including industry representatives in advisory committee meetings where required by statute. FDA is required to include an industry representative in today's meeting under 21 U.S.C. 355N3C. Industry representatives are not appointed as special government employees, nor are they regular government employees. Industry representatives serve as non-voting members of the committee. Non-voting industry representatives represent all regulated industry and are not associated with any company, product, or ingredient, and bring general industry perspective to the committee. Under FDA regulations, although a non-voting member serves in a representative capacity, the non-voting member shall exercise restraint in performing such functions and may not engage in unseemly advocacy or attempt to exert undue influence over the other members of the committee. There are speakers from the Center for Disease Control and Prevention, CDC, a guest speaker and industry speaker at today's meeting who will give a presentation to the committee, answer questions from the committee, and hand the meeting back over to the chair. They will not participate in committee deliberations, render advice to FDA, or vote. The CDC speakers and guest speaker are participating in this meeting, are presenting the views of their organizations and not their own personal views. The following guest speaker, Dr. Bart Hockmans, has declared no financial interest and has been cleared to participate in the meeting. In the interest of transparency, FDA asks guest speakers to disclose any personal financial involvement with a firm, product, or other entity affected by the committee's discussions to allow the audience and the committee to objectively evaluate their presentation. Today's guest speaker has not reported any such relevant interest. Doctors Darren Edwards, Rituparna Das, Kaivan Marjarad, and Tanya Kolpitz are the invited industry presenters for Moderna, Pfizer, and Sanofi, respectively, who are participating at the request of FDA to provide updates to their COVID vaccine products. They are not voting or non-voting members of the advisory committee and will not participate in committee deliberations, discussions, or voting. Consistent with the Federal Advisory Committee Act and FDA Advisory Committee procedures, invited speakers who provide informational presentations and do not serve as committee members are not subject to the same financial conflict of interest screening requirements applicable to special government employees appointed to the committee. The presenter's role is limited to providing factual and contextual information to assist the committee's understanding of the subject matter. Accordingly, no conflict of interest determination under 18 U.S.C. 208 was conducted for these presenters. The presenters will not participate in committee deliberations or recommendations. FDA asks that all participants, including the open public hearing speakers, advise the committee of any financial relationships that they have with any affected firms, its products, and if known, its direct competitors. We would like to remind the members that if the discussions involve any products or firms not already on the agenda for which an FDA participant has personal or imputed financial interest, the participant needs to inform the DFO and exclude themselves from the discussion, and their exclusion will be noted for the record. Thank you. Dr. Perlman, I hand the meeting back over to you.
Okay, thank you, Dr. Rees. So next I'm going to introduce Dr. Jerry Ware, who's the Director of the Division of Viral Products, Office of Vaccines Research Review, CBR FDA. And Dr. Ware, if you're online here, please turn your camera on and turn your microphone on and tell us your part of the talks.
Thank you. And good morning to everyone and welcome. As Dr. Perlman said, I'm going to provide just a very brief introduction to today's VRBPAC meeting. Next slide. Oops, that's not it. Next slide, yes. Okay, so this slide simply states very simply the purpose of today's committee discussion. We're here to review the SARS-CoV-2 surveillance and epidemiology data, genetic and antigenic characteristics of recent virus isolates, serological responses to current vaccines, and the availability of candidate COVID-19 vaccines. This is for the 2026-27 formula. And then during the discussion, the committee will be asked to make recommendations for the composition of the 2026-27 formula for COVID-19 vaccines for use in the United States. The next slide simply outlines today's agenda, which you've probably already seen in the in the briefing material. Following this introduction, we'll have an update on the current epidemiology of COVID-19 and an update on SARS-CoV-2 variants that are currently circulating. This is from Natalie Thornburg of CDC. Following Dr. Thornburg's talk, Dr. Amanda Payne will give an update on COVID-19 vaccine effectiveness. She's also from CDC. And following those two CDC talks, we will get a report from the WHO TAG COVAC, who meets twice a year and discusses this, essentially the same thing that we're discussing here at this VRBPAC, and that will be presented by Dr. Bart Hegmans from Rotterdam in the Netherlands, and he's on the WHO Technical Advisory Group. Following the TAG COVAC presentation, we will get presentations from each of the 3 licensed COVID-19 vaccine manufacturers in the United States. This is Moderna, Pfizer-BioNTech, and Sanofi. And then we will have an FDA presentation that sort of wraps it all together and leads us into the voting questions. And these will be considerations and recommendations for COVID-19 vaccines for the 2026-27 formula, and that will be provided by Dr. Carol Weiss of the FDA. There will be an open public hearing, more additional question and answers, and then the committee will discuss and vote. I have one more slide to show, the next slide, which just briefly reminds everyone of the process that we use here for this meeting. This is a summary of the process that we've used for COVID-19 vaccine strain composition. Several years ago, the Vaccines and Related Advisory Committee discuss the process and the methodology for making strain composition recommendations for COVID-19 vaccines for the U.S. We did this in April 2022 and followed up with a follow-up discussion in January 2023. And what the result of those discussions, the committee agreed with a general framework that we have proposed that consisted of the following steps. In collaboration with other U.S. public health agencies, the FDA will routinely monitor and review the epidemiology of circulating SARS-CoV-2 variants in the United States, the effectiveness of available vaccines that are in use, the available clinical data, available non-clinical data, and any current vaccine manufacturing issues. And then on a regular basis, but at least yearly, the FDA and the VRBPAC will review the most recent data to determine whether to recommend an updated COVID-19 vaccine for use in the United States. The goal of this process is to reassess current vaccines and decide if an improvement is needed and can offer benefit. The current annual target for review is late spring, early summer, and this essentially coincides with the availability of recent vaccine effectiveness data and serology study data from current vaccines. I would remind you that in any event of a concerning change in the virus landscape or the emergence of a more pathogenic escape virus in the context of a public health emergency, we would have an emergency ad hoc meeting of the VRBPAC and discuss necessary steps. The third step that the FDA does in this process is to review the discussions and recommendations put forth by other regulatory groups and public health agencies. We have an ongoing collaboration with different regulatory agencies around the world. And finally, in a series of technical working group meetings, the FDA discusses clinical and non-clinical data generated by the manufacturers of U.S. authorized and approved vaccines and any current manufacturing issues that might impact vaccine availability. So that's our process. I think you've all pretty much seen this before. But after all of the discussion, we will have a voting question and a discussion question, and you'll see this in the next slide. The committee will be asked to vote, have one voting question, and they will be asked for the 2026-27 formula of COVID-19 vaccines in the U.S. Does the committee recommend a JN1 lineage XFG variant as the preferred variant for an updated monovalent vaccine? That will be our voting question. The committee will be asked to vote yes, no, or abstain. And then we'll have a follow-up discussion, which will become obvious as you hear the presentations today, and that's on the final slide. And this will be a discussion topic for the committee. You'll be asked to discuss the circumstances that may warrant recommendation of a non-JN1 lineage variant, for example, BA.3.2 for COVID vaccines use in the United States. So that's the introduction. I'm happy to take any clarifying questions before we move on, if there are any. Over.
Thank you, Dr. Weir. So we have time for a few questions, if there are any from the committee. I see one hand, Dr. Gantz.
Thank you so much for that update. I just had one quick question. Can you discuss the process if we wanted to set the stage for future bivalent? We've had a bivalent in the past, and as we understand with other respiratory viruses, there may be a dominant strain. There may actually be two dominant strains. We're going to hear more about that as we hear our presentations today, but just sort of methodologically and sort of policy, can you help us understand what this committee potentially responsibility or what we would do if that was something that we wanted to consider?
I can give you a sort of a high-level view. I mean, obviously, we would be interested in hearing what the committee thinks about something like this and whether you thought the data suggested that such a composition was needed or would be useful. I will tell you that we would probably require quite a bit of data to support such a recommendation, but that data could be forthcoming if manufacturers and others presented it or obtained it and presented it. So I think at this stage, we would probably be in the listening mode and want to hear what you and the rest of the committee thought about this, whether it was practical, whether it was needed, whether there was sufficient data to support such a recommendation.
I see no further hands being raised, so I want to thank Dr. Weir for his succinct discussion of what we're going to discuss today. And I would like to introduce the next speaker, who is Dr. Natalie Thornburg, who is well known to us as the chief of the laboratory branch, the coronaviruses and other respiratory viruses division at the NCID, at the CDC. And she's going to discuss the current epidemiology of COVID-19 and SARS-CoV-2 variants. So thank you, Dr. Thornburg.
Thank you so much, Dr. Perlman, and thank you to my FDA colleagues for inviting us to share where we are with COVID-19 and SARS-CoV-2 genomics since we last spoke about this time last year. So first, I'm going to give you an update on the epidemiology of this past year, and then I'll move into the genomics in the second half of my talk, and I will cover about 30 slides. Next slide, please. Or bring up the slides, please. Let's see. Sorry, is anyone else seeing the slides? I am not seeing the slides.
Yeah, we can see them.
Okay, sorry, I just have the incorrect view up on my screen. Okay, we'll just my apologies here. I will just wing it here. Okay, so please bring up the slide that says the national SARS-CoV-2 weekly percent positivity, and I'll start from there.
On slide 3 at the moment.
Okay, great, thank you. Okay, so since SARS-CoV-2 emerged, we've observed a pattern of periodicity with peaks in the late summer, August, September, and then the early, and then like winter, like November, December, January. So this graph I'm showing right now is a graph from our National Respiratory and Enteric Virus Surveillance System dashboard, which is a passive surveillance system that collects the number of total tests run and the number of positive tests within those number of total tests run. We display the data as a percent positive over time to indicate the approximate community circulation of the virus. And as you can see from this graph, which covers 2021 to 2026, we display the data as percent the magnitude of peaks increase around that late fall and then early winter. The peaks this past year on the right side of the graph were a little bit lower than they have been in years past, and the percent positivity was a bit higher last fall than the winter peak of this year. Next slide, please. So much like percent positivity, we have seen periodicity due to COVID-19 associated hospitalizations, which follows the same timing of those peaks. So this figure shows the weekly rates of COVID-19 associated hospitalizations among all ages, and this is weekly hospitalizations, November 2024 through April 2026. Since November 2024, rates have peaked in January 2025, September 2025, and then again in January 2025. Next slide, please. This graph also shows hospitalization data, but it is population-based risk of hospitalization by 12-month surveillance period as the cumulative rate. So this is not weekly rates, this is the cumulative rates. As a reminder, the cumulative rates are the sum of the weekly rates. And at this point in the ongoing 2025 to 2026 season, which is indicated by the red line at the bottom, rates are lower than all previous seasons since October 2022 to September 2023 and have increased or have decreased with every year. These continued reductions in cumulative COVID-19 associated hospitalizations should be caveated, however, because they're within the backdrop of circulation of viruses that have all descended from the same or similar viral lineages. And the current lineage emerged in fall of 2023. Therefore, it's likely there is a fair amount of population immunity in the majority of circulating against the majority of circulating viruses from infection. And it's unclear if these trends will continue if a strain replacement event were to occur. Next slide. So that graph was from all ages. Looking at hospitalization rates over time only provides part of the picture, and we can break down the cumulative population-based COVID-19 associated hospitalizations by age group. And this data in this graph is shown for October of last year to April of this year. So only part of 1 year and during a time when we didn't have a whole lot of circulation. Data for the ongoing surveillance period of October to April from our COVIDNet shown here indicates that adults 75 years of age and older have the highest rate of COVID-19 associated hospitalization, followed by young infants less than 6 months, and then third, adults age 65 to 74 years, with young children 6 months to 23 months of age in fourth place. Keep in mind, these are cumulative rates for a 7-month period, so not a full year of data, which means the absolute values of hospitalization rates are incomplete because we haven't had our summer and fall wave yet. But in short, COVID-19 continues to cause substantial rates of hospitalization in young infants and older adults. Next slide, please. So I wanted to give you a point of reference. So we wanted to compare the cumulative rates of hospitalization by age of COVID-19 and compare it to influenza. So this is a comparison of those hospitalization rates of COVID-19 to influenza using the same network with so it's the same network, the same sites using the same or very, very similar methods. So COVID-19 associated hospitalization rates in young infants and older adults in recent years are in line with the rates of hospitalization for influenza, another respiratory virus that's been recognized for decades to have substantial public health impact on the very young and older adults. The left panel on this slide show comparison of hospitalization rates by age group of COVID-19, which is in darker gray, and influenza is in the lighter gray during the 2024 to 2025 surveillance period spanning October 2024 through September of 2025. The right panel shows the same comparison for the current surveillance period, so October through April, with the caveat that COVID-19 associated hospitalization rates only reflect fall-winter activity, and it is a year-round circulating virus. So we're expecting to see those rates increase if there is a late summer wave following historic periodicity patterns. Hospital outcomes are similar for COVID-19 and influenza. Next slide, please. When we look at risk factors for hospitalization from COVID-19, we have found that underlying medical conditions, any adult with underlying medical conditions are at higher risk for COVID-19. So adults with one or more underlying medical conditions are at increased risk for COVID-19 hospitalization compared to those with no conditions, with the highest risk among younger adult age groups. Among adults ages 18 to 49 with no underlying conditions, those with comparing to those with at least one underlying conditions were 4.6 times more likely to be hospitalized for COVID-19, whereas adults ages 75 and older, no conditions comparison to one or more were 2.2 times more likely to be hospitalized with COVID-19. Next slide, please. So the previous slides talk about risk factors in adults, but given that hospitalization rate in young infants is second to adults older than 75, what are the risk factors in children? So a published analysis of COVIDnet data showed that more than 40% of children and adolescents and 76% of infants who were hospitalized due to COVID-19 had no underlying medical conditions. The first analysis, which was among children and adolescents associated ages 6 months to 17 years who were hospitalized due to COVID-19, reported 41% had no underlying conditions, but some conditions increased the risk for severe in-hospital outcomes due to hospitalizations to COVID-19, including intensive care unit admission, receipt of medical ventilation or extracorporeal membrane oxygenation, or in-hospital death. The conditions were chronic lung disease, cardiovascular disease, diabetes, and neurological disorders, including cerebral palsy. A second manuscript published analysis reported that among infants less than 6 months of age who were hospitalized due to COVID-19, 76% had no underlying medical conditions. Next slide, please. So when we circle back to adults to look at specific risk factors, so based on a recently published peer-reviewed study of adults, age is the strongest risk factor for COVID-19 associated hospitalization. Most chronic death conditions examined in the study further increased that risk. The table here shows age group stratified rates of COVID-19 associated hospitalizations among adults. The middle column shows adults with no underlying health conditions, and the right column shows those with at least one condition. The specific conditions are listed on the slide. The hospitalization rates among adults 75 years and older with no conditions was 583 per 100,000, which exceeded the rate among adults aged 65 to 74 with one or more health conditions at 531 per 100,000, which is shown in bold. Among the other age groups, adults with at least one underlying health conditions had higher hospitalization rates than in older age group with no health conditions. In adults 18 to 49 with no health conditions had the lowest rate, but were still at risk for COVID-19 hospitalization. Next slide, please. So in summary, overall, and age-specific weekly rates of COVID-19 associated hospitalization continue to peak in both summer and winter. Rates of COVID-19 associated hospitalization remain highest among the youngest, less than 6 months of age, and the oldest, greater than or equal to 65 years age groups. Among adults, age is the strongest risk factor for COVID-19 associated hospitalization, and chronic conditions increase risk for COVID-19 associated hospitalizations. Okay, next slide. I'm going to pivot into the genomics update. Next slide, please. Okay, so this is just sort of a picture of where the evolution of the virus has gone from the very beginning, the emergence of COVID-19 in late 2019 into the present tense. Specifically, this plot shows a randomly sampled subset of SARS-CoV-2 sequences from the past 4 years, with the x-axis date of collection and the y-axis is the number of spike, the S1 domain of spike protein substitution, so amino acid substitution, relative to the ancestral SARS-CoV-2 strains. The COVID-19 vaccine strain composition is along the top. You can see the gray says original. There was that period where we had bivalent vaccine with both ancestral and a BA.4/5 formulation, XBB.1.5 for 1 year, a JM1 KP2 specific formulation for a year, and then last year, orange JN1 LP.8.1. So overall, you can see the number of substitutions, mutations has been accumulating over time, but then you can see a couple of big jumps, which you probably remember from the COVID-19 pandemic of strain replacement events when a new lineage emerged and had some sort of growth advantage and quickly assumed predominance in circulating viruses. So you see that Delta to Omicron jump from Delta purple to orange, and there is an arrow. There was a BA.4/5 lineage jump to XBB lineage jump. And then the last sort of strain replacement event we saw was in November-ish, November, December-ish of 2023, 2024, when XBB lineage was replaced with BA.2.86 lineage virus, JN1 lineage viruses, which have continued to circulate since that time. Next slide. So some of the more Okay, thank you. So some of the more recent vaccine updates when we saw a strain replacement event, I'm going to show you on the surface of a crystal structure of spike protein, just so you can visually see how many changes in spike occurred during those vaccine updates. So this is 3 different views of a spike protein crystal structure. Spike is a protomer or is a trimer, so it has three identical protomers. 2 of the protomers are shown in gray, and 1 of the 3 protomers is colored. You have a side view there on the left. On the middle, you have a top view, and then on the right, you have sort of a zoomed in side view of the receptor binding domain, which binds ACE2 and is the primary target for neutralizing antibodies. And then that's in like red and green. And then the blue is the N-terminal domain, which can also have some neutralizing antibody binding activity, probably sterically, like larger antibodies, if they come in at the right angle, can block ACE2 binding to the spike protein and block the virus from binding cells. And so each one of those boxes is a substitution. So a change in an amino acid in comparison to the 2 lineages that are listed in the title. So this is XBB.1.5 to JN1. And what I want you to see is there are a lot of boxes and there are a lot of changes. So there was an update in the vaccine that was 2 years ago now. Next slide, please. As I said, the last sort of strain replacement event happened in late 2023. So the viruses that were circulating last year were much more similar to the viruses, to the vaccine formulation. And so this was the update that was made last year, 2025. Same views of the spike protein. You can see ACE2, the cellular binding, or the cellular receptor on the right in yellow. And with the boxes, the difference is this is specifically looking at KP2 JN1 and LP.8.1, the changes, and there were not a lot of changes last year. Okay, next slide. So where are we genomically right now? Okay, so the first The first thing I will point out, which is obvious, typically if you look at our genomics dashboard, there will be a bar on the right, which is grayed out, where we have modeled data. So we collect sequences every month and we calculate those. Using those sequences, we calculate growth rates and decay rates of different viruses that are circulating to model into the present the proportion of viruses that are circulating in the present. Our last reporting period was May 8th, so typically we would have had modeled data up to May 8th, but during that last reporting period, we did not have enough sequences to accurately model into the present tense the proportion of viruses that are circulating in May. So our most recent data looks at empiric data, which is actual sequences. We can just use the actual sequences to see the proportion of viruses circulating nationally. And that was for the month ending April 11th. What I want you to take away, these are a lot of different letters, as is COVID genome or SARS-2 genomics. Things look different, but every virus on this list is a JN1 lineage, except for kind of in the middle there in red is BA.3.2. I'll talk a little bit more about that one later. But all of these other viruses are JN1 descendants. So that is greater than 95% of circulating viruses as of April 11th were JN1 lineage viruses. Next slide. All right, this is a dendrogram of the list of viruses that I just showed you. It's not a phylogenetic tree. It's just to show you the relationship of the viruses on that list, and everything. I understand this is difficult for you to read. Basically, everything on that list is up there in the top right. And if you kind of follow that back to the root of that dendrogram, you can see they all descended from JN1. With the exception of BA.3.2, it's kind of over there on the left, right above BA1. And so that is represents a different lineage of virus. Next slide, please. Okay, so how different are the viruses that are circulating right now? This is just a table with some of the key spike substitutions in the spike protein of some of the viruses that are circulating now and that have been circulating over the past year in comparison to LP.8.1. So there's some in the N-terminal domain, some in the receptor binding domain, some and then some outside the receptor binding domain in other parts of the protein. And what I want you to see here is that there are a fair number of viruses, but they are all quite similar to each other and relatively similar to LP.8.1 with, the most important regions as far as inducing neutralizing antibodies, that receptor binding domain. There are only a handful of substitutions in that receptor binding domain and then a few extra in the N-terminal domain with an insertion. Next slide. Okay, so this is just a crystal structure very similar to the ones I showed you before with current circulating viruses. So this is one, XFG.1.1 is currently the most prevalent lineage, and it has 13 spike substitutions, and this is in comparison to JN1. And you can see some of those map to the receptor binding domain, some of them are in that N-terminal domain blue, and then some of them are just elsewhere in the protein. Next slide. This is that same virus, XFG.1.1, but this is in comparison to LP.8.1, which was one of the formulations last year. So there are 13 substitutions in comparison, 12 substitutions in comparison to LP.8.1. Next slide, please. Okay, and this is one more virus, prevalent virus that is circulating right now. It's NB.8.1, which is a recombinant virus, but it is also a JN1 lineage that's very similar, and it has 12 spike substitutions in comparison to LP.8.1. So hopefully you're getting the message that most of the viruses that are circulating are very similar to each other. Next slide, please. The one I mentioned earlier that I said I would talk more about is BA.3.2. So we just put that on the genomics dashboard last reporting period. It had just reached enough sequences to be, we call it broken out. And you can see there as of mid-April, we were, it was representing about 4% of viruses. Next slide, please. And you can see it is sort of above that BA1 in the dendrogram. Next slide. Okay, so this is an alignment of some of the changes and sort of a situational report of BA.3.2. So this is a lineage. It's divergent. It was first detected in a respiratory sample collected in November 2024, so quite a while ago. And it contains 58 substitutions, 5 amino acid insertions, and 13 amino acid deletions. So 76 total differences compared to LP.8.1. It is quite different. But it emerged quite a while ago, and it has been very slow to sort of catch hold. Next slide, please. This is a crystal structure with the number of substitutions projected onto the surface of LP.8.1, and there are a lot. So it is a very different virus. Next slide. It has been circulating long enough. It has been able to itself begun to diversify a bit. And this is just a table of some of the sublineages that have been evolving from BA.3.2 and some mutations in it. It's colored. This isn't all spike substitutions. So spike is in red, nucleocapsid blue, other open reading frames in green. And there's not a lot of diversification in the spike protein. There's 1 or 2 substitutions in the spike protein within BA.3.2 lineages, and then mutations in other proteins. Next slide. So I have already told you that it has reached about 4% of circulating of virus sequences from about a month ago. And additionally, we are detecting it in U.S. wastewater surveillance. So there have been BA.3.2 detections in 36 states or territories as of about, I think, a month ago. So it does seem to be circulating at a rather low level in the community. And on this graph on the top, it's sort of the red. So you can see it. You can see it going back about 6 weeks ago. So it's there, but it is not rapidly reaching predominance. Next slide. And I think this is my last data slide. Okay, so there's several sort of preprints. This is from some collaborators in the SAVE network. Several preprints looking at neutralization of different circulating viruses collected. This is with human sera collected before vaccination from last year's formulation and after vaccination. And the take-home message is that vaccination with last year's formulation boosted neutralizing antibodies against all tested viruses, including BA.3.2. Neutralization of BA.3.2 was generally a bit lower. The titers were a bit lower than other viruses, including XFG and NB.8.1. which are some sort of current viruses, but it still did boost neutralization titers against it. And when you take that neutralization data and you graph it in a way to show antigenic cartography, to show antigenic relatedness, LP.8.1, NB.1, XFG, they cluster fairly closely together, especially after vaccination, whereas BA.3.2 clustered away from those XFG viruses, which is unsurprising given the number of substitutions in the spike protein. Last genomics summary. Next slide, please. Okay, so conclusion of genomics for the past year. Most lineages that are currently circulating are descended from JN1. The JN1 circulating lineages have very similar spikes proteins with 8 to 13 substitution in comparison to last year's formulation. And most prevalent lineages are FXG sublineages, and NB.1.8.1, which is a recombinant XFG or a recombinant JN1 virus. The majority of detected viruses, a small minority of detected viruses are BA.3.2 descendants, which are phylogenetically distinct from all these other circulating viruses. It was first detected quite a while ago. It has increased in proportion globally, and there are some countries where it has reached a fairly significant proportion of viruses, though those countries prevalence has not gone along with a big wave or increased hospitalizations or anything. And BA.3.2 sublineages have continued to diversify a bit. Next slide, overall conclusions. So circulation has continued to peak late summer and fall, and then again in the winter. The rates of COVID hospitalizations remain highest among the youngest and the oldest age group. And they're in line in these age groups with influenza-associated hospitalization rates. And despite lower circulation, we estimate a fair number of a fair amount of morbidity. Most circulating viruses continue to be JN1 descendants, and a minority of detected viruses were BA.3.2. And last slide. And I just want to acknowledge the CDC team and our collaborators who have generated all of this data, our NERVS surveillance system, the RESPNet surveillance network, our variant and genomic surveillance system, as well as the SAVE network. And that's all. Thank you.
Thank you, Dr. Thornburg, for a very thorough discussion of your topics. And we will have time for some questions. Before, I'd like to start with one question. One thing you didn't discuss was the epidemiology of BA.3.2 in the very young, where it seems to be a little different. Could you discuss that briefly?
You're correct. I did not discuss that. So it is a little bit difficult. There are several reports out there suggesting that a higher proportion of BA, that very young children are showing the greatest proportion of BA.3.2, and that there is sort of a bias in the sequences that are getting uploaded, a greater proportion in children, I think 2 and under or 4 and under. It's a lot of that data has come from just web scraping of sequences. So it's hard to say if it's absolutely a firm bias, because it's not, those sequences aren't always collected in a systematic way, because we're scraping whatever sort of sequences. So if you have a pediatric network that is collecting specimens and sequencing, it may create some false bias, but it's been repeated and it's been observed in enough sort of independent locations that it may be a very real thing, and that BA.3.2 may be infecting young children. And evolutionarily, that might make sense if it's a bit more similar to like a BA.2 virus, which circulated in the spring of 2022, that those of us who were alive and maybe had infections or vaccinations have some pre-existing immunity, and anyone born sort of after that might not have pre-existing immunity. So biologically, it does make sense, and it's, has been observed.
Okay, thank you. Dr. Gans?
Thank you so much for that wonderful talk. I had several questions, so I'll just ask one and come back if there's still time. But in terms of the epidemiology and what we're seeing in the less than 6-month-olds, I think that in the context of understanding that and what immunity we might be able to give them, given that they're not eligible for vaccination, have people looked at what is the rates in the vaccinated moms versus non-vaccinated? How are we passing on any immunity to help protect those children? And should the message maybe be more persuasive in terms of how moms can help their babies? That's my first question. Thanks.
Thank you for that question. I'll give a one or two sentence question, but then if I can also maybe pivot to my colleague Fatima Dawood, who's online, who may be able to give a slightly more thorough. So just warning you, Fatima, I'm going to call on you, Dr. Dawood. So, I mean, in other respiratory viruses, there is good evidence, like RSV, that transplacental antibodies can provide some protection for young infants who may be too young for vaccination, and that's certainly an approach that is being used for a respiratory virus infection like RSV. Now, the second part of your question, if we've looked at that specifically for COVID-19, I'm going to call on my pediatrician colleague, Dr. Dawood. Are you there?
Hi, yes, I'm Fatima Dawood at CDC. I'll just add that we do monitor maternal COVID-19 vaccine effectiveness through the VISION network. And we've also seen studies from other networks from recent seasons that continue to demonstrate that COVID-19 vaccination during pregnancy provides protection to infants. And I think, as we've sort of been alluding to, that is the only way to protect infants less than 6 months of age. So what we are seeing even in recent seasons is COVID-19 vaccination is effective when given during pregnancy.
I guess I just need to make the point that I think we need to look at those infants and see if moms were vaccinated or not, because that message would be important for people to hear, whether or not that could be helpful.
That is a great note. Thank you.
Okay. Thank you. Dr. Durbin?
Thanks so much. I just have a question around the BA 3.2, and I wonder, do we have data on fitness or transmissibility of that virus? I mean, is there a concern that one of the reasons it hasn't really taken off is that the mutations that it has make it a less fit or less transmissible virus, and that continued mutations may allow it to sort of break through that and become a greater source of infection? Thank you.
Yeah, I want to say that there's some laboratory data to say that the spike has maybe slightly lower affinity for ACE2, kind of has lower affinity for the ACE2 receptor than some of the other viruses. So that could be one way it is less fit, is that it's laboratory data. So that it does have a little bit less binding capacity than our other circulating viruses. So that certainly is one way. Also laboratory data, just anecdotally, I can say it is kind of difficult to grow, and it's kind of slower, like it has slower kinetics than a lot of the other clinical isolates that are coming in. So I think there are probably, it may be a less fit virus, and a new XFG or something new we haven't detected yet could easily come in and displace it. Because when we see a displacement event, it's usually like fast, like it has happened before. We typically week over week growth rate of something that we have has a doubling time of something that's very fast, has like a 7 to 14 day. So it is taking hold before we even can get our feet under us. And that is not the case with this particular lineage.
Thank you so much.
Dr. El-Sali?
Thank you for the presentation. I have a question that also pertains to the BA 3.2. Part of trying to make a guess at the strain to include in the vaccine is understanding the current immunity of the population and what is missing in terms of immunity. We do know that the JN1 and its sublineages have been circulating for more than 2 years, multiple infections, 2 rounds of seasonal vaccinations with JN1. And you just showed us that vaccinating with a JN1 lineage type vaccine will boost responses to B A 3.2 by 2-folds or so. But what is the, do we know what is the reverse? Meaning, do we have data from infected persons with BA 3.2? Do they have reasonable boosting of JN1 lineages, including the XFG?
That's a great question. I'm hoping Dr. Hogman will comment on this. I believe that the TAG COVAC was able to see a little bit of data about the sort of like antigenicity, immunogenicity of BA.3.2. There was just a preprint published on the 26th from the SAVE network that I didn't have time to get into my slides, where it was in animals, so mice and hamsters, where they vaccinated with different mRNAs, vaccinated mice, I think, and then they infected hamsters and mice with BA.3.2 viruses and then other viruses. And the BA.3.2 antigen virus did not elicit very good neutralizing antibody titers against like all of the XFGs and older viruses. So it didn't induce good neutralization against the other viruses. And it didn't even elicit all that great neutralization titers against itself. So at least in that one very small study, it did not appear to be a particularly good antigen. And that was out of Derek Smith, Mike Diamond, and Mehul Suthars. So if you look up that preprint, it's on bioRxiv.
I mean, the complication here is that the population has seen JN1 in multiple fashions for the last 2-3 years, so it's a bit different. Yeah. And back boosting in humans is a phenomenon. So, but thank you for that. I'll look up this publication.
Okay, thank you. Dr. Gans, can we hold your question till a later discussion?
Yeah, sure. I'll come back to it. Thank you.
Okay, thank you. Okay, so thank you, Dr. Thornburg, again for great discussion. And I wanted to introduce the second FDA speaker, Dr. Amanda Payne, who's the acting team lead of the Prevention Effectiveness and Evidence Review Team of the Surveillance and Prevention Branch. And she's going to talk about updates on COVID-19 vaccine efficacy.
Thanks so much. So as I said, my name is Amanda Payne, and I'm an epidemiologist in CDC's National Center for Immunization and Respiratory Diseases. And today I'll be presenting updates on COVID-19 vaccine effectiveness. Next slide, please. So I'll start today with context and methods for how we measure and interpret vaccine effectiveness, or VE, and then present estimates of 24-25 COVID-19 VE from last year, followed by a summary of what we know so far about VE of 25-26 COVID-19 vaccines. I'll end with a summary of data regarding COVID-19 VE by genetic differences between variant and vaccine composition. Next slide. Okay, starting with context for interpretation of results and a summary of VE methods. Next slide. Patterns of prior SARS-CoV-2 infection can impact measured COVID-19 VE. This graph provides some context for interpreting VE during the 24-25 and 25-26 seasons by showing the proportion of persons with infection-induced immunity by age group. On the top, in green, are estimates among children and adolescents during November to December 2022. On the bottom, in blue, are estimates among adolescents and adults during October to December 2023. Although the time periods are different, the takeaway is that across age groups, almost all people in the US have experienced at least one SARS-CoV-2 infection, meaning they have some level of infection-induced immunity leading into the season when VE was measured. Past infection can provide some protection from future infection, and VE findings should therefore be interpreted as the added benefit provided by COVID-19 vaccination in a population with high prevalence of infection and vaccination-induced immunity. Next slide. Vaccine uptake can have implications for our ability to measure VE, as uptake in a population needs to be high enough to have sufficient statistical power. The four figures here show COVID-19 vaccination coverage measured as one or more doses for 4 age groups: all adults 18 years and older on the left, adults ages 18 to 49 years old in the middle left, adults 50 to 64 years old middle right, and adults 65 years and older on the right. In each figure, coverage for the current 25-26 season in dark blue is compared with coverage for the previous 24-25 season in light blue. The figures show that coverage decreased overall and across all age groups from the previous 24-25 to the current 25-26 season. Overall, among adults 18 years and older, on the figure on the left, coverage decreased 4.8 percentage points compared to the end of February last season. For those 65 years and older, on the figure on the right, vaccination coverage decreased 9.4 percentage points in the most recent season. Next slide. Now let's look at COVID-19 vaccination coverage estimates for the pediatric population. Overall, approximately 9% of children between 6 months and 17 years of age were up to date on their COVID-19 vaccinations at the beginning of March 2026. This represents a drop of 3.3 percentage points from the coverage at the beginning of March 2025. Note that due to both low COVID-19 vaccine coverage in children, as well as relatively lower baseline rates of disease compared to earlier seasons, VE in children could not yet be estimated for the 25-26 season. Next slide. In the two data sources I'll present today, we use a test negative design, or TND, to measure COVID-19 VE. For respiratory viruses, the TND is a robust, timely, and efficient way to measure real-world VE. In a TND, everyone who meets a clinical case definition, in this case, persons with acute respiratory illness, or sometimes called COVID-19-like illness, is enrolled. This means that enrollment isn't based on test status, but on a clinical case definition. Those who test positive for SARS-CoV-2 are classified as cases, and those who test negative are classified as controls. Finally, immunization status between the groups of cases and controls is compared. VE is then calculated as 1 minus the odds ratio times 100%, with the odds ratio comparing the odds of vaccination among cases and controls. In practice, adjusted odds ratios are calculated using multivariate modeling. Next slide. The TND has several key features that make this study design advantageous. Unlike clinical trials, the TND is conducted under real-world circumstances. Study start is based on symptomatic medical encounter, and furthermore, the TND is designed to minimize bias due to differences in health-seeking behaviors because all persons in the study have sought care for acute respiratory illness. Next slide. Vision, the first of the two sources of data I'll share today, is a multi-site network of electronic health records at over 300 emergency departments and urgent care clinics and over 200 hospitals. Vision includes eligible people of all ages with COVID-19-like illness and a clinical test within 10 days before to 72 hours after their encounter. Cases are those with a positive NAT or antigen test for SARS-CoV-2 and no positive RSV or influenza test. Controls are those with a negative NAT test for SARS-CoV-2 and no positive NAT for influenza or RSV, depending on age. Vaccination is documented by electronic health records and state and city immunization registries. Next slide. The IV network, the second of the two sources of data I'll present today, is a multi-site VE platform in 26 hospitals in 20 US states. Unlike Vision, IV uses an active enrollment design with patient interviews and swabbing of enrollees. Participants included in analyses presented today were adults aged 18 years and older with COVID-19-like illness. Cases had a SARS-CoV-2 positive NAT or antigen test, and controls were negative for SARS-CoV-2, influenza, and RSV by RT-PCR. Vaccination history is ascertained through electronic medical records, state and local vaccine registries, and self-report, and specimens are collected for central testing and sequencing. Next slide. I'll now share a summary of 24-25 COVID-19 VE from data collected during the period when 24-25 vaccines were available. Next slide. This slide shows 24-25 COVID-19 VE against emergency department and urgent care encounters, including data through September 2nd, 2025, which coincides with when the 25-26 vaccines became available. The format of these slides will be similar throughout the presentation, with the first column showing the stratification, the next two columns showing the counts of and proportions of cases and controls by vaccination status, the next column detailing the median interval since last vaccine dose, and the far right column showing the VE estimates. Here we stratified COVID-19 VE estimates by age group, 9 months to 4 years, 5 to 17 years, 18 to 64 years, and 65 years and up. You can see that VE is estimated to be as good or better among children as it is among adults, and this aligns with previous seasons data. Next slide. This slide shows VE against COVID-19 associated hospitalization among adults 18 years and older without documented immunocompromising conditions in the Vision and IV networks. The slide is laid out the same as the previous slide, except instead of age groups, it shows results for Vision in the top block and IV in the bottom block, and we're stratifying by time since vaccination. VE during the study period was similar across the two networks, providing reassurance of the results. Among those vaccinated 7 days to roughly 10 months prior to their encounter, the point estimate was 35% in Vision and 40% in the IV network. Moderate protection was noted among those who received vaccination 7 to 179 days prior to their encounter, but evidence of waning protection was noted among those that received vaccination 180 days, or roughly 6 months or more prior to their encounter. Next slide. This slide shows VE against COVID-19 associated critical illness, which includes admission to intensive care or in-hospital death, by time since dose among adults aged 18 years and older in the top block, and then further stratified to those 65 years and older in the bottom block. Similar to VE against COVID-19 associated hospitalization, VE against COVID-19 associated critical illness is highest among those vaccinated 7 to 179 days prior to their encounter, with point estimates decreasing among those vaccinated 180 days or more prior to their encounter. However, confidence intervals were wide and overlapping. Next slide. These data from IV show VE for various COVID-19 associated severe in-hospital outcomes among adults aged 18 years and older, and then among adults 65 years and older. The format of the slide is similar to the previous slides, except instead of time since vaccination stratifications, we're stratifying by the type of severe in-hospital outcomes. In general, we see an increasing trend in VE point estimates with increasing severity of outcome. This mirrors what we've seen in previous years. VE estimates against the most severe outcomes are the most robust. Next slide. Finally, this slide shows VE against COVID-19 associated hospitalization among adults with immunocompromise in Vision in the top block and IV in the bottom block. VE for the overall time period was 24% in Vision and 23% in IV, with confidence intervals overlapping those of estimates of VE in non-immunocompromised adults, providing reassurance that the vaccine is working in immunocompromised adults. Next slide. Next, I'll summarize what we know so far about 25-26 COVID-19 VE in adults. Next slide. This slide shows 25-26 COVID-19 VE against COVID-19 associated emergency department and urgent care encounters among adults aged 18 years and older in the top box, and then stratified by age group in the bottom portion of the slide. Among those vaccinated 7 to 179 days prior to their encounter, 25-26 COVID-19 vaccination was about 50% effective. VE estimates were similar by age group, with confidence intervals in the 18 to 64 years age group, where we have lower vaccine uptake and we have wider confidence intervals in this age group due to less statistical power. Next slide. This slide shows COVID-19 VE against COVID-19 associated hospitalization among adults aged 18 years and older, and then among adults aged 65 years and older, all without immunocompromise during the 7 to 179 days after vaccination. Among adults 18 years and older who were vaccinated 7 to 179 days prior to their encounter, 25-26 COVID-19 vaccination was about 60% effective. VE estimates were similar among adults aged 65 years and older, and there were no obvious signs of waning effectiveness with more time since vaccination. But it's important to note that the longest interval since dose among those that received vaccine was 179 days in this analysis. Next slide. And this slide shows 25-26 COVID-19 VE against COVID-19 associated critical illness among adults 18 years and older, and then among adults 65 years and older. Again, estimated VE was about 50% in both groups, but confidence intervals were wide, and we did not have enough statistical power to evaluate VE by time since vaccination. Next slide. Finally, this slide shows 25-26 COVID-19 VE against COVID-19 associated hospitalization among adults with immunocompromise. These estimates are remarkably similar to those among adults without immunocompromise, with estimated VE being about 55%, again, providing reassurance that the vaccine is working in immunocompromised adults. Next slide. Finally, I'll summarize an analysis that was designed to evaluate effectiveness of COVID-19 vaccines by genetic match to circulating SARS-CoV-2 strains in the United States. Next slide. As Dr. Thornburg previously showed, COVID-19 vaccines have been updated annually to keep pace with SARS-CoV-2 evolution, which has occurred through a combination of gradual accumulation of spike protein mutations and infrequent evolutionary jumps. Next slide. These jumps have been associated with decreases in COVID-19 VE in prior studies from Vision and Ivy and other networks. However, the impact of gradual spike evolution on VE is largely unknown. This analysis, using whole genome sequencing in the Ivy network, investigated whether small to moderate mismatches with the vaccine strain can also impact protection against hospitalization. Next slide. A metric for spike genetic divergence was defined, focusing on the S1 domain because it's the primary immunogenic domain. For each sequenced case patient, the total number of non-synonymous mutations in the S1 relative to that season's vaccine strain was calculated. For example, in this schematic, this particular sequence would have 3 mutations or mismatches compared to the vaccine strain. This provides a summary metric of divergence that has been shown to correlate well with laboratory antigenic distance across different variant predominance periods in multiple studies. Next slide. This table shows selected characteristics of the hospitalized adults by case and vaccination status included in this study. In total, 17,597 adults met inclusion criteria, among whom 2,727 were case patients and 14,870 were control patients, an approximately 1-to-5 ratio. The median age overall was 66, and COVID-19 case patients and vaccine recipients tended to be slightly older. 17% of adults received COVID-19 vaccination, including 11% with XBB.1.5 based vaccination and 6% with KP2 based vaccination. The analytic period spanned September 2023 to April 2025. 59% of adults were enrolled during the 23-24 period, and 41% were enrolled during the 24-25 period. Next slide. This figure shows the number of COVID-19 sequence cases by count of spike protein S1 domain mutations relative to the COVID-19 vaccine strain. Overall, you can see this is a bimodal distribution, and there's a group of low divergence viruses with 0 to 10 mutations and a subgroup of high divergence viruses with 28 to 35 mutations, which represents the emergence of JN1 in late 2023 during a season in which XBB.1.5 vaccines were used. Next slide. We'll start by looking first at how VE is impacted by the large evolutionary jump we saw with the emergence of the JN1 lineages. And then we'll review, next slide, our findings by splitting the low divergence group into finer strata. Next slide. This figure shows VE against hospitalization stratifying by both genetic divergence category and time since vaccination, with additional columns for proportions of vaccinated patients, median time since dose receipt, and standard error, a measure of estimate precision. The figure is organized by time since vaccination first, and within each time since vaccination strata, we have 2 genetic divergence categories. VE against COVID-19 associated hospitalization in the first 89 days after vaccination was 48% and 43% for SARS-CoV-2 viruses with 10 or fewer mutations versus 28 to 35 mutations, which are fairly similar. VE diverged more substantially 90 to 179 days after vaccination, with protection sustained at 48% in the low genetic divergence group, but now encompassing 0% or no protection for the high divergence group. For vaccine received more than 180 days earlier, VE for both groups included the null, though precision was lower for viruses with 10 or fewer mutations. Next slide. Next, we break out the low divergent SARS-CoV-2 viruses into categories of 0 to 2, 3, 4, 5, and 6 to 10 mutations. For COVID-19 vaccine received 7 or more days earlier, VE against COVID-19 associated hospitalization was 68%, with wide CIs for 0 to 2 mutations, and more similar and precise estimates of 49%, 45%, 44%, and 38% for the remaining groups spanning 3 to 10 mutations. The point estimates seem to suggest decreasing VE with increasing divergence. Next slide. But you can see that median time since dose increases steadily across these groups. So natural waning of immunity could also be an explanation. Next slide. When limiting to the first 7 to 89 days after vaccination to account for differences in time since vaccination, the point estimates for the first 3 groups are mostly unchanged. The point estimates for the 5 mutation and 6 to 10 mutation groups shift up, suggesting that at least some part of the trend we saw before could be driven by natural waning, though these estimates are imprecise. This imprecision occurs because these viruses with higher mutation counts only begin circulating later in the season, once more time since vaccination has elapsed. There are some limitations to keep in mind with these findings. First, as we showed, spike mutation counts correlate with time since vaccination, making it challenging to differentiate natural waning from variant-mediated effects. Second, all mutations were assumed to have the same effect when calculating the genetic difference. Finally, data were limited to 2 seasons of COVID-19 circulation, including only 1 major strain replacement event, the JN1 emergence. Next slide. Early data from Canada regarding 25-26 COVID-19 VE indicate similar findings. While this study evaluated effectiveness of monovalent LP.8.1 vaccines, no positive cases in this study were characterized as LP.8.1 lineage. Nevertheless, the estimates were robust. Perhaps VE estimates were robust, perhaps due to the limited genetic distance between the vaccine formulation and the most common circulating viruses. Next slide. So to summarize what I've presented, in a population with high levels of infection and/or vaccine-induced immunity, compared to no 24-25 dose, 24-25 COVID-19 vaccination provided additional protection against medically attended COVID-19 associated illness among children and adults, including adults with immunocompromise. 24-25 COVID-19 vaccination provided additional protection against COVID-19 associated critical illness among adults. The protection appeared to be higher and more robust against the most severe outcomes compared to less severe outcomes. Interim VE estimates indicate 25-26 COVID-19 vaccination provided additional protection against COVID-19 associated emergency department and urgent care visits and hospitalization compared to no 25-26 vaccine dose among adults with and without immunocompromise. Next slide. During the 23-24 and 24-25 periods, mRNA COVID-19 vaccines protected against severe COVID-19, including during periods of increased genetic divergence from vaccine strains. Protection was stable against SARS-CoV-2 viruses with low to moderate genetic divergence, but durability was diminished against highly divergent lineages. Importantly, early data indicate the 25-26 COVID-19 vaccines provided protection against non-LP.8.1 lineage viruses that are genetically similar to LP.8.1. Next slide. I want to acknowledge the host of people that have contributed to this work, including CDC staff and Vision and Ivy collaborators. Thanks for your time.
Thank you, Dr. Payne, for a great discussion. So we have time for some questions. Dr. Gans?
Thank you so much for that presentation. It struck me as you were looking at the differences in time since vaccination and the protection, particularly against the strains that weren't in the vaccine, so divergent strains. And I wondered, is there a way to overlay other data that we have in terms of, because people are collecting antibody titer data over periods of time? And is there a way to overlay that? I mean, we're struggling here to understand a seroprotective titer. And when we see some of the neutralization of these other strains, but we have a titer that we don't fully understand, it feels to me like we are starting to collect some of the data that we would need if we could actually pair data from two different study modalities. I know you're working with databases. They're not collecting antibody data, but somehow we need to be able to interface or overlay that data with that so that when we're presented with neutralizing titers, we can start to understand if that quote boost is enough for us to say that there could be some cross protection. And it feels to me like you're alluding to it in your epidemiology data. So I wondered your thoughts on that.
Yeah, thanks. That's a great question. I'm actually going to reach out to Kevin, or to Natalie. We're coordinating. Because I think she has some thoughts on how we would pair those serologic assays and some thoughts maybe perhaps around like concerns around standardization of the assays and how, how we make fairer comparisons. Dr. Thornburg, do you have thoughts on that?
Yeah, I mean, I definitely hear what you're saying, and I think we're sort of getting closer to an idea of general neutralization titers that correlate maybe with effectiveness, but standardization of of serological assays is notoriously difficult, especially when we are talking about functional biological assays like neutralization assays. It is simpler when one is looking at a binding assay that can be, provided by a manufacturer with a quantitative standard and just easy standardization where there's not a lot of places for variability in the assay. But when you're talking about assays that like you make a virus, the viruses are different, the source cells of the viruses are different, you're dealing with cells for the neutralization, there can be, and then like what is a reference sera and how do you source that reference sera? That standardization and like getting to a number is much more difficult than it would seem. And so, in the kind like pseudovirus neutralization versus neutralization with like a virus, it is practically speaking very difficult to have that kind of standardization. Yeah.
However, we do need it, and it feels like we have the epidemiology data that needs to be paired with it.
I hear you. And having networks that are collecting both the effectiveness data and have sequencing like collecting the specimens to do the sequencing has been invaluable, and that's what the data that Dr. Payne and Dr. Ma produced was from that kind of network that we also had sequencing from the same network as effectiveness data.
Thank you. Dr. Rubin?
Thanks, Dr. Payne. Very interesting discussion. I'm curious about the fading immunity over time and the effect of revaccination in people who are getting revaccinated with the same vaccine 6 months later. Do you have an idea of the effectiveness of that?
Yeah, we do. We didn't present it today, and I actually don't have it in backup slides, but we did look at it for the 24-25 season. So among adults 65 years and older who were eligible to receive that second dose, like 6 months or more, we did see a boost in effectiveness. The estimate was not statistically significant, so I will acknowledge the confidence intervals were wide. I think a lot of that is due to lower vaccine uptake. It's where you saw it in the intro slides, where uptake is certainly not as high as we would hope. And then uptake of that second dose is, as you can imagine, even lower. But we did see, I don't have the number off the top of my head, but I think it was somewhere around a VE of like 20%-ish around VE against COVID-19 associated EDUC encounters. So we did see a little bit of a bump there in the folks that got the second dose.
Thank you.
Thank you, Dr. Omer.
Yeah, a couple of questions. Could you please provide data, if you have available, on maternal immunization coverage, particularly in the context of high risk in infants of disease and outcomes, if those data are available? And the second thing is, has CDC modeled a potential scenario where, in the context of waning immunity and in the context of this somewhat, settling pattern of periodicity, what is the optimal window of vaccination? And so, of course, the so-called waning protection varies by outcome, et cetera. But has there been any formal exercise to evaluate some options around this?
Yeah, thanks so much. So your first question, I know that we have some data online around vaccination of uptake among pregnant women. I don't have firm numbers in front of me, and I can get those towards the end of the second Q&A if that would be helpful. I will say, just in general, uptake in that population of the vaccine is quite low. And that has hampered our ability to measure COVID-19 vaccine effectiveness among the youngest infants in the most recent season, for sure. Despite them having the highest, some of the highest rates of severe illness, or the infants having the highest rate of severe illness. But I will circle back with the actual numbers on what we know around coverage among pregnant women. I will, to your second question around modeling, and I think maybe what you're asking is, these vaccines tend to come out in August. We've seen the wave, the summer wave, sometimes right after or right before these vaccines are available, and could that be timed better? I think there are a lot of considerations with timing of the new vaccines. I'll actually defer to FDA on sort of timing of this meeting in relation to all of that. But I think it is a good question. I do. Back to the previous question around, did we see a bump among those 65 and older that got their second dose? I think the availability of that second dose was meant to try to mitigate the issue of the sort of bimodal peaks and having more recent protection be provided right before a peak happens. But I'm not aware of any modeling data from our side.
Thank you. Dr. El-Sali?
Thank you for the presentation. I wonder if this question is for you or for Dr. Thornburg, or maybe both. As we are settling into a new epi of COVID-19, into more endemic, seasonal type circulation, and to understand it in context of these other viruses, Dr. Thornburg showed us a comparison with flu, for example, the epi in comparison with flu. Do the IV network and vision network, the ones that on which the data relies, utilize the multiplex PCR? In our hospitals, we are still relying on the COVID, RSV, and flu PCRs only for costs reason. But for those particular networks, are we getting the multiplex PCR to understand more where the epi of COVID-19 is going, comparatively speaking? Yeah.
Yeah, it's a great question. So I can speak for the IV and vision networks on sort of what we have available. And then maybe Dr. Thornburg, if you want to chime in on the COVIDNet data in particular. So for vision, it's clinical testing. I will say within our sites, many of our sites are similar to your facility, using the multiplex test. So we do see, anyone who's had many people who've had a SARS-CoV-2 test also have an influenza and RSV test. And actually both platforms, IV and Vision, are used for RSV VE and flu VE as well. Ivy takes it one step further and has additional centralized testing. So that's a similarly a multiplex panel that gets run when specimens are collected. Dr. Thornburg, do you want to comment on the COVIDNet data and testing in that network?
Yeah, COVIDNet data is like Vision, it's clinical testing. So I expect in the adult enrollees, it is like a quadruplex is often used, but in the pediatric cases, it may be more like a larger panel. And then in addition to that, our NERVS, our passive surveillance network, which doesn't collect vaccine effectiveness, it's just about circulation of viruses, that collects any clinical testing that happens because it's such a sort of diverse set of laboratories that are just like uploading their data. And then additionally, we do have a surveillance system called NVSN just for true surveillance that's pediatric with a broad case definition, a broad ARI case definition, and they do research testing, not clinical testing. So they enroll ARI and patients, and then they do testing for all respiratory viruses and some bacteria that cause respiratory disease, so that we get that helps us get a better picture of the true sort of community transmission of any of the respiratory viruses. But it's the purpose. We have lots of different surveillance system, with each surveillance system, filling a different need and having different testing practices and enrollment practices to fit the need that it's addressing.
Okay, thank you.
Okay, thank you. I think we need to move on now. So I want to thank again Dr. Thornburg and Dr. Payne for really great presentations and discussions. So the next speaker is going to be Dr. Bart Hagmans, who's from Erasmus Medical Center. And what he's going to present is the deliberations from the TAG COVAC WHO meeting held over the last few months. And the committee made recommendations on antigen composition, which he will discuss. So Dr. Hagmans.
Yeah, thank you so much, Dr. Perlman, for the introduction, and the FDA for the opportunity to present the viewpoint of the Technical Advisory Group on COVID-19 Vaccine Composition, so the TAG COVAC. And I'm going to talk about the COVID-19 vaccine antigen composition of May 26. Next slide. So at the moment, I'm chairing the TAG COVAC, and the other members really cover quite some ground. So it could be immunologists, virologists, but also people working in public health. Next slide. So the main aim and task is to recommend to WHO whether adaptations to the antigen choice for the COVID-19 vaccine is needed. We look also at critical data, and I think also the point made on methods to assess the impact of the variant, and also the neutralization assays is one thing we look at critically. And it's all these data that we take together on the update of the recommendation. Important to say that twice per year we meet, and the last meeting was 7 and 8 May, where we made the decision. Next slide. So as you all know, updates have been made in 22, the bivalent vaccine, and then followed by the XB1.5, Gen 1, and last year the LP81 vaccine update made by the TAG COVAC. So the question really now is there a need to update the monovalent LP81 vaccine? That is the starting point. Next slide. So the TAG COVAC looks into all kind of different data available. That is genetic evolution, the epidemiology of the different variants, and most importantly, looking at the antigenic characterization. So this could be monospecific sera that indicate the antigenic differences that can be done by antigenic cartography, but also looking at immunogenicity data from sera obtained either from animals vaccinated multiple times, and more importantly, from humans with the vaccines already available. And vaccine effectiveness estimates are looked at. And last but not least, I would say, is also data from the vaccine manufacturers, because often they have data on the new antigens and the immunogenicity of these antigens, either in animal models or hopefully in human studies, clinical data on preliminary data on potential vaccine candidates. So this is the ideal situation that we have those data. So these will be presented by the vaccine manufacturers, so I cannot present those at the moment. Next slide. Next slide, yeah. So first of all, we look at the circulation of SARS-CoV-2. Previous slide, sorry. The circulation of SARS-CoV-2 in different geographical regions of the world. So we're not only looking at the US, we look at Americas, Europe, Africa, and so on. And as you can see in the blue line, and that was indicated already earlier, overall activity of SARS-CoV-2 is really very low at the moment. And if you look back to 25, we see in the red line that peaks were seen, especially in Americas and Europe, in the early autumn and sometimes also in winter. And we have to see whether the pattern, for example, if you look Europe and Americas with the peaks around that time, will that continue in the coming years? We don't know. But overall, the activity is quite low. So this also impacts, of course, our estimation of the different variants that are circulating, because the input of sequencing, especially in regions like Africa and the Western Pacific, is relatively low. So there's limited sequence data. So it's also difficult sometimes to predict what's happening and to see what's happening at the moment. Next slide. But overall, if you look back at what happened from mid last year till now, and that was indicated also, is that initially we have seen an increase of XFG derived variants, which is diminishing now, but still the XFG and other GN1 lineage viruses, including especially the NB181 in some regions, especially in Asia, are the major variants seen. And BA3.2 has increased, and especially here in Europe, in the Netherlands, but also in Germany, we have seen that there was some dominance of BA3.2. But interestingly, I think it seems to peak and was, especially if you look at Germany, for example, quickly displaced by NB181. So that's an interesting pattern, and we do not fully understand what will happen. So this makes it a little bit uncertain on the evolution and the dominance of BA3.2, which is we have to look at. And so the data from the more recent months are a bit difficult to interpret, especially because of the low input of sequence data. Next slide. And so the question whether BA3.2 is not really dominating as we could have expected maybe is indeed maybe caused by a relative less fitness of this virus, and this indicated in this figure. There is limited data on this, I would say. On the right, you can see infectivity with BA3.2 pseudotype viruses being less able to infect in cells. I think we have seen this also in our lab that, for example, CALU3 cells are very difficult to infect with isolates of BA3.2. On the left, it's the competition with soluble ACE2. So in BA3.2, you need more soluble ACE2 to compete. So also indicating potentially that the affinity to ACE2 is lower. And this could be one of the reasons that it's more difficult to outcompete other variants. Next slide. So one important aspect is looking at the antigenicity of variants, and this data from my own lab, from my lab, is, and that's shown in the lower two panels. So these are two different BA3.2 isolates tested against different antisera, monospecific antisera, which were generated after infection of hamsters with these different variants. And you can see that whatever antiserum you take, it cannot neutralize BA3.2. So this already indicates that BA3.2 is antigenically quite different. There are only a few animals, these are the same on the right, on the left panel, that have some neutralization, but it's very, very limited. In contrast, if you look, for example, XFG in the upper right, you see that XFG homologous neutralization is strong, and there is neutralization of variants that are related from Gen 1 lineage, and less extent the earlier variants. Next slide. So these data you can then plot in an antigenic map, and that's shown here. And so in gray and black, so the circles are the antigens, the viruses, and the squares, the colored squares, are the antisera. So in the lower part of the panel, you see the pre-Omicron viruses, then moving to the early Omicron variants from BA2.45 to XBB.1.5, which is in the very top of this cluster, and then the real separate cluster of Gen 1 lineage viruses, which also includes the XFG. And so the positioning of BA3.2 is far away from these clusters, but is also difficult to make because there is hardly any cross-neutralization. So there's a bit of uncertainty where these viruses are located. But next slide. If you look at data obtained from other groups, and these include the Suter lab, but also the Breiburg lab on the right, with data from non-human primates. So these are sera, again, from monospecific infections, showing again a similar picture with BA3.2 being far away from what we originally mapped. In mice on the left from the Suter lab is a bit different, a bit more close. So there was some cross-reactivity in mice against BA3.2. On the right, I think it's also important to note that in the green cluster, you see XFG and LP81 being mapped quite close together. So it's important. Next slide. Next, yeah. Next slide, please. I don't see it move. Next slide. Oh.
We're on slide 13.
Okay, that's good. So these were the antigenic mapping data. One back, sorry. So in this slide you already seen, I think it's indeed an important slide showing the neutralization data of the LP81 vaccine in humans. So sera taken before and after vaccination. On the left boxed, red boxed part of the graph, you see that the LP81 vaccine induces strong recall response, boosting response against LP81 as expected, but also against NB181 and especially XFG. So the LP81 is quite immunogenic and it boosts viruses that are in the Gen1 cluster and the Gen1 lineage. So that is quite clear. On the right boxed, red boxed area, you see, as previously indicated, that in contrast to the naive infected animals, in humans, you do see a background neutralization against BA3.2. And in some cases, this is even higher than the neutralization seen against XFG. So it is also important to note. And across the studies, I would say there is a 2 to 4-fold increase in the induction of antibodies against BA.3.2. Next slide. Yes. And so this is another study showing similar data, similar outcome, in the sense that the responses seen after LP81 vaccination against LP81 and B181 and XFG are quite strong, and a 2 to 4-fold increase is seen in the BA.3.22 responses. So this is quite similar as the earlier data. Next slide. Yeah. So if you then go back to data obtained after JN1 vaccination, I think an interesting observation in the two different panels shown here, A and B, is that in A panel are the ones that have been tested nucleocapsid antibody negative, so didn't experience probably infection. The lower panel did have neutralizing antibodies against the nucleocapsid. And in general, you see that responses either before and after vaccination are quite more pronounced. Overall, the responses seen after JN1 vaccination are relatively lower than what we have seen after LP81. Of course, I can't show all the data, but this is representative, I think, what we have seen. Next slide, because this also holds for the KP2 vaccination. And this is data from Florian Kramer's lab showing that if you look at the homologous neutralization of KP2, it's quite strong after the KP2 vaccination, but you do see that the titers reached for XFG and NB181 are relatively low. And I think notable here on the very right is if you look at the BA.3.2 responses, they are higher than seen after than the XFG responders. So I think this is also what we see in some studies, and it's more pronounced in some than others. Next slide. Then looking in the general population, I think it's also important to note indeed that several studies, including a study from South Africa here, showing that in time, especially if you look at the neutralization against BA.3.2, increased in time from 22 to 25. So I think that's important to note. Next slide. And the other thing is that from data from China have shown, and this is Yongmeng Chao data, showing that if you look at BA.3.2, there seems to be a bit different pattern that the ones that were mRNA vaccinated in the past, because there is not really updated vaccination schedules in China, you see that they seem to have a bit better response against BA.3.2 than the ones that received the inactivated vaccines in China. Of interest to note, but we don't know exactly what's happening here. Next slide. It's a bit slow. Next slide. Yeah. On the VE data, I want to be very short. I think the data presented by Dr. Payne were quite informative, and what has been seen in the data we were provided with is that the VE effectiveness data range from 40 to 60%, and there's limited data on the LP81. But I think that the presentation of Dr. Payne was quite informative in that. So I'll and with a summary of available evidence. I think it's important to note that the TAC COVAC actually looks specifically available evidence is important. So if we look, I won't go to all the points made, but I think it's important to note that at the moment it's difficult to estimate what will happen with the BA.3.2 in that there is heterogeneous dynamics in different countries across different parts of the world. So we have to see whether there will be changes in this pattern. Next slide. The neutralization data and the data I've shown from the antigenic cartography clearly indicate that naive animals infected with or vaccinated with Gen1, LP81, and XFG map closely together, and that BA3.2 is really distinct. So that's important to note. As I've shown, I think, and I indicated these are important data, is that the data we have seen from LP81 vaccinated individuals across different studies indicate that not only the LP81 responses were boosted significantly and very strongly, but also responses against the other antigens, including NB181 and XFG, are quite strong. And that 2 to 4-fold increases are seen in the responses, which are already present for BA3.2. And one other aspect is that what we have seen is that the Gen1 and KP2 vaccines seem to be less able to induce potent responses similar to LP81. Next slide. So I just can give a short overview of the data from the vaccine manufacturers. I think this will be shown more detail later on. I think it's important to note that, and I mentioned this already early in the beginning, is that in the public space and domain, there's limited data of the novel antigens and their immunogenicity with respect to vaccine antigens in the background of earlier vaccine schedules. So this is important, especially if you look at the choices to be made for the human vaccination, because the monospecific sera are clearly different data than what I've seen in humans in respect to boosting and to newer variants, for example, the BA3.2. But the data from the vaccine manufacturers clearly indicated that the BA3.2 antigen generates anti-sera that are difficult to neutralize the earlier variants. So this is important. And also the use of the vaccine antigen in previously vaccinated animals is also less able to back boost Gen1 responses, including also the response to BA3.2, which is a bit less than what we've seen earlier. This is a bit too fast, but can you go back one? And the last data is and the last section here is that from the human data, there's only one single clinical immunogenicity study that used the BA3.2 candidate vaccine to show indeed also that there is limited back boost to Gen1 to some extent, but not as much as for the LP81 vaccine. And also there seems to be a lower immunogenicity of the LP81 of the responses to the BA3.2, but this is quite limited. So the overall total evidence for these kind of study is quite limited. So this is also important for the TAC COVAC to make decisions on. So next slide. So there are some limitations on the current data, of course. We are hampered by the input on the epidemiological data. Next slide. And of course, immunity to that is in use is not only serological data, serological neutralizing antibodies, it's also T-cell immunity, so there's more than that. Still don't see the next slide. Only a few slides to go. Only two. Yeah, very good. So this is already what I mentioned on persistent and increasing gaps on the AP and genetic surveillance, especially over the last few weeks, months. And we need to see what happens with BA3.2. And the VE estimates are also limited data, I would say. Next slide, and the last slide on the actual recommendation of the TEC COVAC, which was made early May, is that based on the available evidence we have right now, we find that there's no update needed. So the monovalent LP81 is the recommended COVID-19 vaccine antigen. That is to say that other antigens, e.g. XFG and NB181, or other approaches that demonstrate broad and robust neutralizing antibody responses or efficacy against currently circulating variants could also be considered. I think that's very important to note. But we also, of course, need to look at other regions of the world. And for example, in Japan, the idea is, for example, to use, based on the circulation there of, for example, the NB181 antigen. And saying that, we need also to include that in the absence of any vaccines available that are aligned with these recommendations, of course, we need to use vaccines that are available. But clearly, I think we point out that we no longer have a preference for the Gen 1 or KP2 vaccines. I think that's important to note. And the focus is on LP81, but also other antigens can be used. Saying that, I close and I take any questions. Thank you.
Thank you, Dr. Hagemans. We have time for a few questions. Dr. Gantz.
Thank you so much for that very helpful presentation. I had a question. When you had shown the regional epidemiology of viral circulation, do you also have data that can put on that or overlay the vaccination rates within those regions? Because I think it would be helpful for us to understand if, like in the US, people aren't getting vaccinated and so these viruses are just circulating. That's my first question. My second question is, do you have any data on differences? And I think this is something that also our CDC colleagues, I would love to opine in the later session. Are there differences in strains in people who are infected, who are vaccinated versus unvaccinated? So are we selecting out strains and people who are unvaccinated differently than those who are vaccinated? Because it is interesting that we have had, a similar lineage in our vaccines for 2 years, and they do continue to circulate, but maybe there's differences in how we should be thinking about that because vaccinated people are protected against them, at least in the short term.
Yeah, I think for both questions, I think those detailed data we don't have, the overlap and the second question you had. So I think we lack this data. I mean, we don't have the clear specific data on that. That's clear. Of course, indeed, your point also to the BI3.2, that's the only one I think that it indicates that in people that did not receive the vaccine, there's some indication that, especially in the younger ones, that you would see the increase, which is related to the vaccination status. So that could be an indication, but more detailed data in other people that were vaccinated or geographical regions, I think we don't have that full overview. Yeah.
Okay. Thank you. Dr. El-Sally?
Thank you for this very informative walk through the data. I have a brief comment and a question. The brief comment pertains to the issue of fitness. It seems that BA 3.2 was not fit in a VSV infectivity model.
No.
But if we look at it being a predominant strain in Germany and the rise in antibodies in South Africa over a couple of years, it seems to be fit in humans. So, I mean, it's just a caveat to the finding. So that's one thing. But if the slide 21 can go up on the screen again, I have a quick question on that. If someone's in charge of slides, can bring up slide 21. Yes, thank you. So this is the third bullet. A single clinical immunogenicity study using BA 3.2 showed that there's a rise in antibodies to the homologous antigen, but the back boost was overall limited. Is the back boost measured by fold increase in antibodies or absolute? Because when we start with a high antibody level, by virtue of JN1 being the predominant strain for a couple of years, the fold increase sometimes becomes limited, is how we've seen it, depending on the antigen, but it's a general observation. Is that what we're dealing here with?
Yeah, so maybe on the first point made, I think indeed, and actually in my lab, we're also looking at, it doesn't mean that the replication of the virus, for example, in the respiratory epithelial cells is the same. So what we in general have seen that many of the variants that replicate poorly in cell lines, especially the Omicron variants, still are still quite fit in respiratory epithelial cells. So this is one thing. And so we need to look into that. It's interesting that the live virus isolate in our hands, for example, also has difficulties to infect Cal-3 cells, which is human cell. And so also in that sense, there seems to be less fit, but we don't have the full overview. I fully agree. So, and how this explains the dominance of BA 3.2, for example, in Germany, is to me also a bit a puzzle. And also looking into whether there are additional mutations gained in the future, what will this mean? So this is one thing indeed important. And the other thing is indeed the increase, of course, sometimes, and especially in cohorts that, and for example, in UK, we have data from cohorts that received, for example, twice per year the vaccine. So they have relatively very high levels of pre-existing immunity, and then indeed the increase seen seems to be limited, but the overall levels reached is very high. So we need to look at both aspects, and so there's quite some variation in different cohorts analyzed, which sometimes makes it a bit difficult to draw overall conclusions. So it also looking at the data is quite, you need to have a critical look at that, yeah, I would say, yeah.
Okay, so is the back boost here situation by virtue of the background antibody levels being high already that we see a limited back boost, but some back boost?
You mean for the BA 3.2?
Yes.
I think the BA 3.2 is antigenically quite different. So a back boost and an increase is not expected to be very strong. So it is some increase, but it is not really a strong increase because the antigen is quite far away. So that's clear. Yeah.
Okay, thank you.
Okay. Dr. Durbin?
Thank you. That was a really nice presentation. I guess my question may be more philosophical given the recommendation to stick with LP 8.1, but we're seeing XFG emerge in the presence of vaccination with LP 8.1, given that we know vaccination rates are not all that high. The question is this an immune response, or is this the virological response to vaccination with LP 8.1 that we're seeing emergence of a new strain? Or how do you explain the emergence of XFG, and are we going to continue to see that take over even more if we continue vaccinating with LP 8.1? I mean, it's difficult to know, I know, because we have lower vaccination rates. So it seems suppression by vaccination wouldn't entirely explain the shift. But I'm a little nervous if we're seeing emergence of this variant in the presence of LP 8.1 vaccination. If we stick with LP 8.1, you know, can we project sort of continued emergence or less effectiveness of the vaccine in the future? Thank you.
Yeah, of course. I mean, it's very difficult to match fully the ones that are circulating. And this will be also now. The question is what will be circulating in the winter season? We don't know. And that will be quite potentially a bit different from the ones that are now. So even the XFG will have some escape. And that is what makes the difference. I think in general, the WHO is a bit more conservative on that sense and really looking at the antigen and what is based on the evidence we have, the best evidence we have, and that is the data that is provided, whether we see differences. And with that respect, we did not see really significant differences, for example, XFG and NB181. So that's also included in the outcome. Yeah, so that is the point. I mean, and we have to look at different regions of the world. So clearly, Japan is looking at NB181, for example, and other regions in the world have the availability of other antigens, including LP81 as the preference. So, but I think that's why the statement is a bit more broad, including also that XFG and NB181 can be used, I would say. Yeah.
Thank you.
Okay, Dr. Berger.
Thank you. That was a great talk. And I want to go back to a question that Dr. Gans sort of posed at the very beginning around the potential for a bivalent vaccine. Did the WHO discuss this? Was this part of what the TAC was looking at in terms of what was circulating and whether there was a need or a potential desire to shift back to a bivalent form?
That's a very good point. But it goes back to, I think, the same issue. Is there sufficient data available? And that can be quite difficult. So, and especially on the bivalent, there is not sufficient data available at the moment. So we also have to look what will be the data coming up in the coming period. But this is a general point I would make. I mean, this is also on the BA3.2 antigen in humans, there's limited data. So, I mean, this is also a problem. So, and then the combined vaccination strategy, yeah, we as a committee would need to see the data, I think, more data on that. So we didn't really discuss that.
Thank you.
Thank you for the question.
Okay, with that, I think I see no more hands, and I think it's time for a break. And thank you very much, Bart. That was really great. So we will take a break now and return at the hour mark. I think it's, yes, at the hour mark. So 11 a.m. Eastern Time. Are we ready to get restarted?
Yes, sir. We're live.
Okay. So I want to welcome everyone back to the meeting of the 192nd meeting of the VRBPAC to discuss COVID-19 vaccine selection. And next, we're going to hear from the manufacturers. So the first manufacturer will be from Moderna. And I want to emphasize to all the industry presenters that they have 20 minutes, including questions. So keep their presentations as efficient as possible. So the first presenters will be Dr. Darren Edwards and Rita Parno-Das from Moderna. And I think the floor is yours.
Thank you, Dr. Perlman, and good morning. My name is Darren Edwards, and I'm the program leader for COVID-19 vaccines at Moderna. We are pleased to provide the committee with an update on our COVID-19 vaccine development, including data relevant for the upcoming season. Now that COVID-19 has become endemic, it remains a leading cause of morbidity. COVID-19 was the second leading cause of hospitalizations among respiratory viruses in 25-26, accounting for 120,000 to 250,000 hospitalizations. Additionally, it was estimated to cause 13,000 to 41,000 deaths. Data from the prior season showed that the majority of those hospitalized had not received an updated vaccine. Moderna currently has 2 COVID-19 vaccines licensed in the U.S. The original Spikevax vaccine, mRNA-1273, encodes the full-length spike protein and was fully licensed in January 2022. It is currently indicated for adults 65 years and older and for individuals 6 months through 64 years of age with at least one CDC-defined high-risk condition. Moderna's next-generation COVID-19 vaccine, mRNA-1283, or mNEXSpike, encodes linked receptor binding and N-terminal domains. It was licensed in May 2025 for 65 years and older and individuals 12 to 64 years of age with at least one high-risk condition. During the 25-26 season, mRNA-1283 comprised the larger proportion of Moderna COVID-19 vaccine recipients in the United States, and today's presentation includes real-world clinical experience and preclinical experience with both vaccines. We have evaluated the safety and effectiveness of our COVID-19 vaccines annually. This has included real-world effectiveness studies capturing more than 5.8 million doses administered. Today, we will review data from 3 real-world effectiveness studies that continue to reinforce the benefit of vaccination. We also conduct clinical trials with each licensed vaccine, and today we will review data for the LP81 vaccine licensed in 2025. Our ongoing assessment of new variants is intended to provide data to support strain selection recommendations by the FDA and health authorities worldwide. We are prepared to manufacture the vaccine recommended by the FDA for the fall season. Let me briefly review the current SARS-CoV-2 variant landscape in the United States. As has previously been mentioned, 2 different lineages of COVID-19 variants are co-circulating globally. Here we see a 2D map illustrating the genetic distance in spike proteins across these 2 lineages. JN1 related variants, shown in green, are clustered together, while BA.322, shown in orange, is separated from the JN1 lineage by more than 70 mutations. On the right, we illustrate that evolution of the virus continues, with subvariants emerging in both the XFG and the BA.322 lineages. Although more divergent, BA.322 remains at low frequency in the US and in most regions globally. Last year at this time, the JN1 subvariant LP81 was the leading variant in circulation in the United States. This is shown in the bar at the far left. The current season is defined by continued circulation of JN1 subvariants, of which XFG is dominant, shown in dark purple. XFG followed LP81 to become the dominant circulating variant in July 2025 and has sustained that position over time. XFG and other currently circulating JN1 subvariants together account for more than 80% of US sequences, and LP81 is no longer circulating. The BA.322 lineage, shown in orange, has been co-circulating at low levels globally for 18 months. Despite periodic increases in some regions, it has been unable to sustain dominance in those regions over the JN1 lineage. Antigenic modeling has become an important tool for assessing expected COVID new variant vaccine performance, and our published model supports our vaccine candidate selection at risk each season. This analysis estimates modeled fold reductions in neutralizing antibody titers between currently circulating or emerging SARS-CoV-2 variants relative to specific vaccine strain formulations. Vaccines are shown in the left of each row, with variants across the top of each column. Lower values indicate better antigenic match, and higher values suggest increased immune escape. For example, a value of 2.6 for XFG indicates a 2.6-fold reduction in XFG neutralizing antibody titers relative to the LP81 vaccine. For the current LP81 vaccine antigen, we see increasing immune escape against newer JN1 family subvariants, including XFG, as shown by values above 2. We also see greater fold reductions against variants in the BA32 family, as shown by values above 4. An XFG-based antigen provides broad predicted coverage across the JN1 family, including the most predominant XFG variants in circulation. In contrast, a BA32-based antigen does not provide the same breadth of coverage against JN1 family variants. These modeled estimates have been made in previous years and have been found to correlate closely with clinical results. These results, along with epi modeling, are supportive of an XFG-based vaccine strain recommendation for the 26-27 season. Now I would like to walk you through the preclinical studies conducted with our investigational new variant vaccines. We prepared an XFG new variant vaccine for evaluation based on its predominance and evidence of immune escape from LP81. In addition, we prepared and evaluated a BA322 new variant vaccine, as BA322 is a distinct lineage despite its low level of circulation. Both primary 2-dose vaccination studies as well as booster studies have been conducted in mice. Today, I will focus on the booster study results in pre-immunized mice, as it is more reflective of the U.S. population, which has baseline immunity from prior vaccinations and infections. To enable assessment of the LP81 and new variant vaccines as a booster dose, animals were initially vaccinated with a 2-dose heterologous primary vaccination regimen of previously approved variant vaccine compositions. This heterologous regimen is intended to provide diverse immunity in mice to SARS-CoV-2 variants that previously circulated, to be better representative of the human population. A single dose of either the LP81 or the new variant vaccines were administered greater than 7 weeks after the primary regimen was completed. Sera were collected before and 2 weeks after the third dose to enable neutralization assessments. Across all preclinical studies, both mRNA-1273 and mRNA-1283 were evaluated with consistent conclusions, and today we will focus on the results from mRNA-1283. Here are the results after the third dose of the XFG vaccine on the left and the LP81 vaccine on the right. Pre-dose 3 titers are in the dashed bars. Post-dose 3 titers are in the solid bars. Matched variants are highlighted in gray. Both vaccines neutralize JN1 subvariants, including the currently circulating XFG and MB181, and increase BA322 neutralization titers in these previously immunized animals, although to a lower degree. Compared to the LP81 vaccine, the updated XFG vaccine yields higher titers against the JN1 subvariants and against BA322. These are the results of another study in mice in which we assessed the booster response following a third dose of BA322 vaccine, shown on the left, and the LP81 vaccine, shown on the right. The BA322 vaccine increases neutralization of vaccine-matched BA322 virus, with low increases in neutralization of LP81. In contrast, the LP81 vaccine strongly neutralized LP81, but lower neutralization for BA322 is seen. So to summarize our preclinical studies, the updated XFG formulation strongly neutralized JN1 family variants, including the currently circulating XFG and MB181 variants. Cross-neutralization of BA.322 was seen in the booster study, but responses were lower than those measured against JN1 subvariants. The updated BA.322 formulation neutralized BA.322. However, cross-neutralization of JN1 lineage variants was low. Therefore, our data supports that an XFG variant vaccine would provide the broadest coverage for variants likely to circulate in the fall. I'll now turn the presentation over to Dr. Rita Das.
Good morning. My name is Rita Das, and I'm the Senior Vice President for Clinical Development in Infectious and Rare Diseases at Moderna. I will now share with you the results of our real-world effectiveness and clinical studies. During the 25-26 vaccine season, we conducted 3 separate real-world effectiveness studies with the licensed LP81 vaccines, both for mRNA-1273 and mRNA-1283. All studies used a retrospective matched cohort design in large U.S. databases, either Veradigm or Optum. Approximately 460,000 to 700,000 persons were included in each study, half receiving the licensed 25-26 vaccine and a matched cohort who did not. Over 80% of the participants in each study had previously received 1 or more doses of COVID-19 vaccine. Vaccine effectiveness across these studies with mRNA-1283, shown in green, ranged from 55 to 67%. Effectiveness was numerically higher in older age groups. Vaccine effectiveness for mRNA-1273 vaccine, shown in blue, was 44 to 49%. As a reminder, these data show additional benefit of receiving an annual COVID-19 vaccine. In these populations with high prior immunity, this benefit is meaningful. I will now share the results of clinical trials conducted with LP81 vaccines. As part of a post-licensure commitment, we conducted 2 studies to assess the safety and immunogenicity of LP81 vaccines licensed in 2025. The study included mostly previously vaccinated individuals, 12 to 64 years of age, with high-risk conditions, as well as adults 65 years and older. LP81 neutralizing antibody responses were evaluated at baseline and 4 weeks after immunization. Around 600 participants were enrolled in each study. No related serious adverse events were reported in either study, and the safety profile, including solicited adverse reactions, as well as unsolicited adverse events, was consistent with prior clinical trial experience for both vaccines. Now, shown here are the immunogenicity results at baseline and day 29 against the match variant LP81 by age group. mRNA-1273 is on the left, and the next generation mRNA-1283 is on the right. Both vaccines significantly increased neutralizing antibody responses at day 29 in persons 12 to 64 years at risk and those 65 years and older. Immune responses were higher for 1283. The pre-specified success criteria for these studies were met. Overall, the immune response in clinical studies is consistent with the benefit that's been seen in real-world studies. Next, I'll review the clinical trial data evaluating cross-neutralization of the licensed LP81 vaccine and an investigational new variant vaccine, BA.322. Now, here are the matched and cross-neutralization responses for LP81 vaccines. mRNA-1273 is on the left, and mRNA-1283 is on the right. Immunogenicity was assessed in a subset of about 50 study participants. An increase in LP81 neutralization was observed for both vaccines, and cross-neutralization of currently circulating lineage variants XFG, NB181, and BA.322 also was observed. However, titers were reduced approximately 2 to 3-fold against XFG and BA.322 compared to LP81. The XFG and BA.322 antigenic changes and immune evasion risk described earlier are reflected in these clinical reduced cross-neutralization titers. We also conducted a clinical study to evaluate the safety and immunogenicity of an investigational mRNA 1273 BA.322 vaccine in 50 adults 18 years and older. Although BA.322 is in low circulation, we evaluated this clinically because it is a distinct lineage. Neutralizing antibody responses were evaluated at baseline and 2 weeks after immunization against matched and other circulating variants. Again, no serious adverse events were reported in the study. The BA.322 vaccine increased matched antibody responses against BA.322. However, reduced responses were observed against other circulating JN1 variants, including XFG and NB181. As was observed in the preclinical studies, the BA.322 vaccine candidate clinically generated narrower and weaker immune responses. Finally, I'll briefly review Moderna's COVID-19 vaccine safety surveillance program. We have evaluated the safety of our COVID-19 vaccines 1273 and 1283 in nearly 73,000 participants in our clinical trials, beginning with the pivotal efficacy study for mRNA 1273 in 2020. Additionally, we have conducted post-approval safety studies involving more than 13 million vaccine recipients. Lastly, we utilize spontaneous reporting systems to evaluate adverse events both at the individual and aggregate levels. More than 1.9 billion doses of our COVID-19 vaccines have been distributed worldwide. Reported adverse event information is systematically reviewed on an ongoing basis. Myocarditis and pericarditis were identified in 2021 as very rare events associated with COVID-19 vaccines. Substantially reduced rates of these events have been observed since then. The safety profile has remained consistent across all approved Moderna COVID-19 vaccine compositions with a favorable benefit-risk ratio. I will now summarize the data we presented today. The currently licensed 2526 LP81 vaccines were effective in preventing COVID-19 related hospitalizations, even in the setting of pre-existing immunity. The vaccines, both 1273 and 1283, showed robust neutralization against the matched variant strain with lower cross-neutralization of XFG and BA.322 strains. The safety profile of the vaccines was consistent with previous data. XFG is now the dominant SARS-CoV-2 variant in the U.S. Both XFG and BA.322 variant vaccine candidates were evaluated. The XFG vaccine provided the greatest breadth of neutralization across the circulating variants. Our data support that an XFG variant vaccine would provide the broadest coverage for the variants that are likely to circulate this fall. We are prepared to supply a COVID-19 vaccine with the FDA's recommended composition by mid-August. As in prior years, we will continue to monitor vaccine safety and effectiveness and provide data on emerging variants. On behalf of Moderna, I would like to thank the FDA and VRBPAC for the opportunity to present our data today. We also would like to thank the many persons listed here who assisted with these trials. My colleagues and I will now be happy to address any questions.
Thank you, Dr. Edwards and Dr. Das. So we are running out of time here. So we have time for perhaps one question, and we can come back to questions later. Dr. Gans?
If you'd prefer to hold them to later, that's fine. I realize we're right at time, but do you want me to just ask or?
Yeah, why don't you do one,
Okay.
and then Dr. O'Mara will answer your question later.
Got it. Sorry, did you say proceed?
Yeah, sorry.
Okay, yeah. I'm struck by the increased titers, but maybe not efficacy of the mRNA 1283, which only has 10 micrograms of that combined product. And I'm wondering why. That's like the first part of that. And I realize that that is not tested in children, so I think that's going to be important. And my last question around that topic is, has that been looked at in association with myocarditis, pericarditis, and potentially why the rates are lower since we initially saw that?
Yes. So thank you for the question. For mRNA 1283, we have consistently seen increased immunogenicity in our clinical trials. And then we saw a suggestion of increased efficacy in our pivotal efficacy trial as well. And then we did see in the real world effectiveness data, the confidence intervals are overlapping. It's not meant to be compared head to head, but the point estimates were a bit higher for 1283. Now, this is licensed for 12 years and above, and we are starting our pediatric development program. And regarding the dose, it is a lower dose, but it is targeting the immunodominant epitopes of the spike protein, the NTD and the RBD, so creating a focused immune response. Now, regarding the myocarditis, we, in general, across the field and across the Moderna COVID, across Spikevax, we have seen reduced rates since after the primary series. So, and that has been consistent year on year. We have not seen any myocarditis in the clinical development program for 1283 or mNEXSpike, but we are monitoring this very closely in post-marketing surveillance.
Okay, thank you. And you will be available later after our break to answer more questions, correct? Okay, so let's move on to the next vaccine manufacturer, which is Pfizer, and Keyvan Majurad is going to discuss the Comirnaty COVID-19 vaccine update. So the floor is yours.
Good morning. My name is Keyvan Majurad. I'm the Global Medical Affairs Lead for seasonal and pipeline viral vaccines within Pfizer. I'm grateful for the opportunity to speak again on behalf of Pfizer and BioNTech to present data that will inform today's deliberations for a strain composition of COVID-19 vaccines for 2026 through 2027. This is a year in which the field has faced considerable uncertainty in tracking and forecasting the evolution and epidemiology of SARS-CoV-2. My aim today is to show that despite these challenges, we've built a reliable and resilient framework for data generation and analysis that continuously monitors vaccine performance and consistently informs the vaccine adaptation process. I'll start with an overview of COVID disease burden in the US, and later describe the trajectory of major SARS-CoV-2 strains. I'll follow with an overview of real-world effectiveness of our LP81 vaccine. I'll then summarize the immune potency and breadth of the vaccine from our phase 3 clinical trial. I'll conclude my presentation with the preclinical evaluation of new strain-adapted vaccine candidates, as compared to the LP81 vaccine. Since its emergence more than 6 years ago, COVID has progressed through multiple epidemiologic patterns, confounding predictions on its seasonality. It's become increasingly apparent, though, that COVID does have a regular periodicity, but is not contained within a specific season. Many comparisons have been made with influenza, but as you can see here in the graph on the left, CDC data for US hospitalizations due to influenza in gray or COVID in blue in those 65 and older from 2024 to 2025 show that flu cases mostly accrue over just a few months and plateau by March, while COVID cases keep accumulating throughout the entire year. But in the end, there is a parallel between these two respiratory diseases. COVID, despite having a lower attack rate now relative to its pandemic peak, still carries a similar incidence of severe disease as influenza among older adults, even in a year when flu transmission was at a high level. When we look deeper into the COVID epidemiology across the entire US population, shown on the right, we find it carries a substantial burden across a range of outcomes. Tens or hundreds of thousands of Americans died or were hospitalized due to COVID from 2024 to 2025. And yet, it's just the tip of the iceberg, as tens of millions still become ill or seek care for COVID in that same year, placing continued stress on individuals, families, communities, and health systems. It's under these circumstances that COVID vaccines maintain a critical role in protecting the public, especially among the most vulnerable and against severe disease. In order to sustain their public health value, we have to ensure that the vaccines keep pace and stay closely matched to this ever-changing virus. To do so requires a multi-layered and integrated framework of evidence generation and analytics, one that we've built to be resistant to the fluctuating dynamics of external data ecosystems. Especially important now as the availability of epidemiologic data becomes ever more diminished and delayed. We set our framework on a foundation of surveillance for virus evolution and epidemiologic trends, leveraging millions of virus genome sequences that have been published to date. This enables us to enhance our ability to forecast the fitness of different virus strains. This is closely coupled with deeper layers of monitoring vaccine performance over the prior year, beginning with year-round assessments of effectiveness in real-world settings and continuing with measurements of immune escape among emerging strains from banked animal and clinical sera. These inputs converge to inform at-risk manufacturing and evaluation of multiple vaccine candidates so that we're ready to supply a vaccine in time for the next year. This year, that process has held, but also has been tested by the unique circumstances of the virus's evolutionary paths towards strains that derive from or are related to LP81, the composition of last year's vaccine, but also diverge to the novel BA.322 strain that's genetically distant from the JN.1 strains that have dominated the COVID landscape over the past 2 years. The predominance of JN.1 derived strains continued through the fall and winter of this last year. Although LP81, the majority strain at this time, a year ago, has had low prevalence, as shown in the blue line at the bottom of the US prevalence plot on the left. However, its recombinant derivative, XFG, shown in green, accounted for nearly 80% of infections last November, but it too has steadily declined over the last few months. A separate branch of the JN.1 cluster, NB181, and its derivatives, shown in purple, has maintained a steady but low presence. In the last several months, the emergent and genetically divergent BA.322 has grown in prevalence, from about 2% to now causing approximately 20% of new infections. When viewed from the lens of mutations in the spike antigen, shown in the 3D models on the right, we see these JN.1 derivatives maintain some differences from one another, but that BA.322 diverges substantially in its number of amino acid changes relative to LP81. Each year, these trends in the circulation of new strains and the genetic differences between them drive our strategy in assessing vaccine performance. And each year, as these new strains emerge, we evaluate the vaccine's effectiveness in that dynamic epidemiologic landscape. We've done this through a long-term commitment to generating real-world data in diverse clinical settings and have found that the evidence validates the vaccine's benefits year after year. To date, there have been more than 500 studies of the Pfizer-BioNTech vaccine's effectiveness, or VE. A core proportion of those studies come from our partnerships with expansive health networks across the US and Europe to measure VE across multiple populations, regions, and clinical outcomes. Each year, those and other independent studies point in the direction of added benefit of strain-adapted vaccines, predicted by trends in non-clinical and clinical data. The preponderance of VE estimates and their range across clinical outcomes have been remarkably consistent, irrespective of vaccine formula, as indicated in the graphic below. In this last year, we continued generating real-world evidence for the LP8-1 vaccine, beginning with assessments of VE against lower acuity outcomes. Here, I'm showing estimates for the LP8-1 vaccine in studies across two large networks, the U.S. Veterans Affairs Health System in the two left panels, and on the right, Health Verity, a closed medical and pharmacy claims database linked to state vaccine registries. In aggregate, these estimates are generated from millions of patients. We found that VE against COVID emergency department urgent care and outpatient visits was consistent across studies at just above or below 50%, a number that captures the added benefit of vaccination over background immunity during the time of XFG predominance last fall when most cases were accrued. In addition to assessing VE against milder disease, we also evaluated effectiveness against severe disease, specifically hospitalization, in a separate study platform called ID Drive. Here, we found effectiveness to be 80% overall and through the first 6 weeks after vaccination, and 70% several months out. Here again, cases were accrued during a period of XFG dominance prior to the rise of BA.322 in Europe, where it's currently predominant. The estimates from these ongoing studies are consistent with those we've generated in prior years with earlier strain-adapted formulas, and with the broader findings in the peer-reviewed literature. Every year, we also carry out clinical studies to evaluate immune responses elicited by our vaccine, not only against the vaccine-matched strain, but also relevant contemporary strains, in order to understand the breadth of immunity that the vaccine provides. This year, we conducted a phase 3 clinical trial in 2 cohorts focused on high-risk individuals for whom the vaccine is currently indicated. In this cohort, implemented to meet a post-marketing commitment, we found our LP8-1 vaccine elicited a significant boost in neutralizing responses against the matched strain at 1 month after vaccination, in both younger individuals with conditions predisposing to severe COVID on the left, as well as adults 65 and older, irrespective of underlying conditions, in the middle, and the total study population on the right. This provides strong evidence that the robust immunogenicity elicited by strain-adapted vaccines in the general population translates to high-risk individuals, especially those in the younger age group. We also evaluated the vaccine's breadth of response against other circulating strains. In this next cohort, we found the LP8-1 vaccine elicits cross-neutralization of the most prevalent XFG and NB181 strains in the US, noted here as XFG11 in green and PQ17 in purple. These neutralizing responses were similar to those elicited against LP8-1, shown in blue. The vaccine's breadth, however, reached a limit in its reduced activity against BA.322, shown in red on the far right, not only in the endpoint titer elicited at 2 weeks post-vaccination, but also in the less than twofold rise from pre-vaccination. Though we always evaluate the vaccine's performance against strains that have emerged over the last year, we also continuously evaluate vaccine candidates that more closely match emergent strains with potential for predominance over the next year. We evaluate these candidates in multiple mouse models with varied immune backgrounds. Although the general population has largely been exposed to SARS-CoV-2 antigens through infection, vaccination, or both, evaluation first in immune-naive mouse studies has become more important as it becomes increasingly difficult to fully mimic the human immune background. Naive models also approximate the experience of very young children and provide the least confounded measurements of relative antigenicity between different strains, which can be visualized through antigenic maps, like the ones shown here that depict neutralizing responses elicited by vaccines noted in the opened colored boxes. The map on the left shows that contemporary JN1 strains are close to one another antigenically, as reflected in their clustering in the top left. BA322 in the bottom right of that left panel, however, is exceptionally distant from these JN1 strains. The map on the right and the boxes below provide context for that distance, showing the antigenic spread between major strains that comprise prior vaccine updates. In the non-clinical study from which the prior antigenic map was generated, we vaccinated naive mice with 2 doses of either LP81, XFG, or BA322 vaccine. The LP81 vaccine, in line with the clinical data, elicited broad neutralization of major JN1 strains and their circulating derivatives, XFG and XFG11 in green, and NB181 and the PQ strains in purple. The XFG vaccine induced a very similar pattern of neutralization as the LP81 vaccine, and neither LP81 nor XFG vaccine neutralized BA322, shown in red. This contrasts with the BA322 vaccine's more potent neutralization of its matched strain. The BA322 vaccine also elicited a much lower, though not absent, response against the panel of JN1 strains. It's also important to understand how these responses in a naive model translate into those in which mice have been previously vaccinated. In this model, we vaccinated mice with a regimen we've used in past studies that has been predictive of clinical performance, exposing animals to the ancestral and early Omicron spikes, antigens to which most adults have been exposed. On this background, we administered the same vaccine formulas as in the naive study, but as a 4th dose booster. Trends in neutralizing responses were similar to the naive model. Here again, LP81 and XFG vaccines were comparable in cross-neutralizing the panel of JN1 strains tested in the prior study. Responses against BA322 were similarly reduced, while the BA322 vaccine again induced a much improved strain-matched response. Although the magnitude of difference was not as large as in the naive study, the almost 7-fold higher neutralizing response elicited by BA322 compared to the LP81 vaccine exceeds the difference observed for prior antigenically distinct strain-adapted vaccines. Given the challenges in developing a single model that fully recapitulates the complex immunity of human populations, we also evaluated these candidate vaccines in the context of an alternate pre-immunization regimen. In this study, mice were again immunized with the ancestral and Omicron BA.4/5 antigens, but then given an LP81 vaccine before receiving either LP81 vaccine again or XFG or BA322 vaccine. This was intended to approximate a more recent JN1 strain exposure in the general population. Here we see much higher neutralizing titers against JN1 strains across all vaccine groups, reflecting the influence of the recent LP81 immunization. We still see similar responses between LP81 and XFG vaccines, and still a much better, near 5-fold higher BA322 neutralizing response elicited by the BA322 vaccine. These data are internally consistent and in line with the broader scientific literature and follow primary principles of evolving antigenicity and virus epidemiology that guide the deliberations on vaccine updates. And in that framework, I've presented a holistic package of integrated evidence that reinforces the public health benefit seen every year, including this last one, of COVID vaccines that stay closely matched to circulating strains, which remains an important principle as COVID-19 disease burden remains substantial in both morbidity and mortality. In this last year, we saw that LP81 vaccine maintained effectiveness against a range of clinical outcomes, which as in past years was anticipated by the vaccine's breadth of neutralization observed in clinical and non-clinical studies. Looking forward, non-clinical models of varying immune backgrounds show that LP81 and XFG vaccines exhibited similar patterns of elicited immunity, but had limited coverage of the antigenically distinct BA.322 strain. Ultimately, Pfizer and BioNTech are prepared to supply a 2026-2027 vaccine formula per the FDA's recommendation and approval. As always, I'm deeply grateful for the support and collaboration of my colleagues at Pfizer and BioNTech, who I represent today. And on behalf of my colleagues, I thank our study participants, sites, investigators, and partners. Finally, I thank this committee, the FDA, and others watching today for your time and attention.
Thank you for a very clear talk. We have time for one question again. Dr. Gans.
Sorry, I seem to be fast to the hand. I did have a question. Thanks for that information. And obviously, it's really great to see consistent data in terms of what we can expect for immunogenicity. Does Pfizer have plans that to continue any work within the under 12 population in the US and bring another vaccine forward for this age group, or is that not something that's in the plans?
Thanks for that question. First, I just want to clarify that our vaccine is actually licensed and indicated for individuals 5 years and older with at least one comorbid condition through 64 years of age. And so in the population of 6 months through 4 years, the Pfizer and BioNTech are working closely with the FDA to ensure we are bringing forward the appropriate package of data to that will be acceptable for licensure of that for that population in the future.
Thank you.
Okay. Well, thank you. Thank you for the presentation, Dr. Majarad. And we're going to move on to the third presentation from the vaccine manufacturers. I'm going to introduce Tonya Kolpitz from Sanofi, who's going to talk about the nukes of the Nuva's, I'm having trouble pronouncing it, Nuvax COVID-19 vaccine update. So sorry for mauling the name of the vaccine.
Thank you, Dr. Perlman. Hello, my name is Tonya Kolpitz. I'm a global project head in vaccines at Sanofi, and I'll be presenting our COVID strain choice for the 2026-27 season, along with rationale. Sanofi is now the official market authorization holder for Nuvaxovid in the United States. Nuvaxovid is a spike protein-based COVID vaccine built on a proven recombinant technology platform and is the only protein COVID vaccine licensed in the United States. Recombinant protein vaccines have been used safely and effectively for several decades to prevent many infectious diseases. In addition, our Matrix-M adjuvant enhances the magnitude, breadth, and durability of the immune response. Together, these components provide a vaccine with favorable reactogenicity compared to alternative COVID vaccine options and comparable efficacy profiles in a large and diverse patient population. Based on an assessment of the current COVID situation and surveillance in the United States, combined with recent preclinical and clinical immunogenicity data, we believe that the XFG variant is the best choice for the 2026-27 season. In the United States, COVID continues to cause severe illness, yet COVID vaccination rates are quite low. Our protein-based vaccine is an important choice for the US population due to its favorable tolerability profile. The XFG variant has been prevalent for more than 6 months and remains dominant in the United States, while BA.3.2 has not become dominant even 18 months after emergence. Importantly, data indicate that BA.3.2 is rarely seen in the older adult population. Additionally, the LP81 variant has not been in circulation in over 9 months. Our data demonstrates that XFG is immunogenic and covers currently circulating variants, including JN1 lineage variants, as well as likely boosting pre-existing immunity against BA.3.2 variants in humans. Recent data indicate that vaccinating with the BA.3.2 variant would not protect against XFG or other JN1 lineage infections. And we note that an XFG vaccine may provide the best protection for the vulnerable older adult population. In the United States and other countries, we see a public health paradox. While COVID continues to cause illness, hospitalization, and death, vaccination rates remain quite low. Many Americans 65 and older decline their COVID vaccination, even though they are at the highest risk of hospitalization. The availability of vaccine choice, including choice of a tolerable and acceptable protein COVID vaccine, could result in improved coverage and lower the risk of hospitalization for many Americans. Next, I will be going through current surveillance and immunogenicity data. Here we have a snapshot of current global COVID variant circulation. We can see that XFG and NB181 are dominant, and that over 80% of currently circulating strains worldwide are JN1 lineage variants, represented by various shades of purple. It is important to highlight the lack of consistent BA.3.2 growth and prevalence globally, despite its emergence long ago, as well as the fact that LP81 is no longer in circulation. The present COVID situation in the United States again highlights the prevalence of JN1 variants, shown in purple, and the XFG remains the dominant variant across the country. We see low levels of NB181 and even lower levels of BA.3.2. We confirm that variant circulation is consistent across the United States, and again note that LP81 is not in circulation. We also looked into the prevalence of COVID variants by age cohort for both Europe and the United States. First, let's look at the 65 and older age group. We can see that XFG is dominant in this age group and therefore a critical concern for older adults, who are a primary vulnerable population recommended to receive COVID vaccines. When we add in the other age cohorts, we can see that the majority of BA.3.2 lineage infections occur in individuals less than 18 years of age, with few cases detected from this lineage in older adults. We show data from Europe where we see higher BA.3.2 circulation, and also the United States, where we see low BA.3.2, and the trend of variant prevalence in age cohorts, with BA.3.2 found predominantly in younger adults, and older adults overwhelmingly infected with XFG, is seen in both locations. This is also replicated when looking at global data. We do believe that vulnerable populations, such as older adults, must have priority consideration during strain selection deliberations. And these data indicate that an XFG vaccine would offer the best protection for this vulnerable older adult population. And we know that previous Omicron variants were highly infectious, and their emergence was associated with increased illness and mortality. BA.3.2, however, has not been associated with disease severity when looking at current clinical and epidemiological evidence. In addition, we have seen no increase in hospitalizations despite the rise of BA.3.2 prevalence in Europe, and this holds true across age cohorts. There is also laboratory data indicating that BA.3.2 is less infectious as compared to JN1 lineage variants, which is shown in this graph on the right. Now I will go through some immunogenicity data supporting our recommendation for XFG as the choice for the 2026-27 season. Here we present preclinical data using a naive mouse model. This graph shows neutralization data against several variants after vaccination with JN1. We can see a decrease in antibody titers when looking at the XFG neutralization as compared to JN1, indicated by the red arrow. In the second graph, we have neutralization data after vaccination with XFG, and can see an increase in the XFG variant neutralization, again indicated by the red arrow, as compared to JN1. These data indicate that newer JN1 lineage variants are starting to show signs of escape from original JN1 vaccination, and that the XFG vaccine is more effective at neutralizing the XFG variant. Looking at a pre-immune mouse model, we find substantial cross-reactivity against currently circulating JN1 lineage strains after XFG vaccination. After an XBB 1.5 followed by JN1 prime vaccination and a boost vaccination with XFG, we see strong and similar neutralizing antibody titers against a panel of JN1 variants. This next graph shows data after double JN1 prime vaccination and boosting with XFG. And we again see robust neutralizing antibody response against a panel of JN1 variants, including XFG and an XFG descendant, XFG11. These data indicate that XFG is a strong immunogen and would likely be broadly protective against currently circulating JN1 variants. Here we show data using human sera from JN1 vaccine recipients enrolled in a clinical study during the 2025-26 season. Neutralization titers confirm the cross-neutralization of JN1 lineage strains with some variation. We have included Omicron BA2 as a reference. We can see that the post-vaccination XFG and NB181 neutralization titers are lower as compared to JN1, again indicated by the red arrow. We have also included XFG descendants, XFG341, XFG11, and XFG251, and an NB181 descendant, PQ281, which all show a similar decline in neutralization titers as compared to parental JN1 variant neutralization. Again, these data suggests that newer JN1 lineage variants such as XFG, NB181, and their descendants may be starting to show signs of escape from the original JN1 vaccination, and an XFG vaccine could overcome this immune escape in humans. There have been ongoing discussions around BA.3.2 as a candidate vaccine, despite low and inconsistent prevalence. Now I will go through some immunogenicity data, providing additional evidence that BA.3.2 is not the optimal variant selection for the upcoming season. On this slide, we again have preclinical data using a naive mouse model, and this time we show data after vaccination with BA.3.2.1. The graph presents neutralization data against JN1 lineage variants, as well as XBB 1.5 as a reference, and a BA.3.2 lineage variant, BA.3.2.1. We can see that the BA.3.2.1 vaccine does not neutralize the JN1 lineage strains, shown in purple. These data suggest that BA.3.2 variants represent an antigenically distinct family, and that a BA.3.2 vaccine would likely not cover JN1 lineage variants, such as XFG and NB181. This is key in light of the fact that approximately 80% of globally circulating COVID strains are JN1 lineage, with the JN1 lineage variant XFG strongly dominant in the United States. Looking in our pre-immune mouse model, with double JN1 prime vaccination, we found an increase in the BA.3.2.2 variant neutralization after a BA.3.2.2 boost vaccination, as expected. We noted that neutralization of the JN1 variants remains elevated after the BA.3.2.2 boost. To investigate this, we looked at neutralization levels of these same variants after double JN1 prime and a mock boost with buffer. What we found was that the levels of neutralization for the JN1 lineage variants, shown in purple, are similar after the mock boost, shown in the graph on the right, and the BA.3.2.2 boost in the left graph, indicating that the BA.3.2 lineage boost did not raise neutralizing antibody titers against the JN1 variants. These data leads us again to conclude that a BA.3.2 lineage vaccine would likely not elicit an immune response to protect against XFG strains or other JN1 lineage variants, such as NB181 in humans, which is especially important for vulnerable older adult populations, who we have seen are predominantly being infected with XFG variants. Next, we will look at data using the human sera from the JN1 vaccine clinical study during the 2025-26 season, where we specifically want to highlight the neutralizing antibody titers against a BA.3.2 lineage variant. What we want to emphasize here are the high pre-vaccination levels of neutralizing antibody titers against BA.3.2.2, shown in blue. There is similar evidence of high pre-vaccination titers against BA.3.2 lineage variants in data emerging from other studies with human sera, and we have similar data using sera from our 2024-25 seasonal clinical study. These antibody titers were slightly boosted and remained high post-JN1 vaccination, where the titers are similar to current JN1 variants, suggesting that a booster vaccination from a JN1 lineage variant, such as XFG, could be sufficient to elicit a neutralizing antibody response against BA.3.2 variants. Here we have a simplified tree of COVID variant emergence from parental lineages. Looking at the JN1 lineage strains, we can see that XFG and NV181 have emerged non-linearly, while both descended from the parental JN1 strain. We can also see that BA.3.2 emerged from an early Omicron lineage, explaining the large number of sequence differences between it and the JN1 variants, and perhaps providing rationale for the high persistent levels of BA.3.2 neutralizing antibodies that may be found in current human sera samples. An important component of our current discussions is the view forward to potential variant dominance during the 2026-27 COVID season. As mentioned right now, over 80% of detected circulating variants globally are JN1 lineage, with XFG representing more than half of those, and NV181 more than a quarter. And our data demonstrates that XFG covers those currently circulating JN1 variants, while a BA.3.2 vaccine does not. We have seen that future variants are likely to emerge from those COVID strains dominating and evolving today, which in this case would be XFG and its descendants. XFG descendants account for more than half of currently circulating variants, while the single BA.3.2 lineage variant, BA.3.2.2, accounts for only 8% globally. And that single sequence has not meaningfully evolved over the past 12 months while experiencing sporadic and slow growth in various regions. As the virus continues to evolve, an update to dominant and diversifying COVID variants provides the best chance to protect against the next likely emerging descendant. In conclusion, we believe the evidence supports XFG as the preferred choice for the 2026-27 vaccine composition. We know that there is a strong U.S. consumer demand for a tolerable COVID vaccine with an established platform. A protein-based non-mRNA COVID vaccine could reduce vaccine hesitancy and improve coverage rates. XFG remains dominant in the United States, continues to diversify and evolve, and XFG descendants will likely continue to circulate and further evolve in the 2026-27 season. BA.3.2 has not become dominant or diversified in an impactful way, even though it has been circulating at low levels and with sporadic growth for many months. BA.3.2 is rare in vulnerable older adult populations and is not associated with severe disease. We also note that LP81 is no longer in circulation. Our XFG vaccine is immunogenic and covers a broad panel of prevalent and currently circulating JN1 lineage variants, which account for over 80% of global COVID circulation. An XFG vaccine would also be key in protecting vulnerable older adult populations who we have seen are predominantly infected with XFG variants. To have an updated vaccine ready for the fall season, we have already started manufacturing an XFG-based vaccine as the single global product for the 2026-27 season. An XFG recommendation would enable timely availability of the only protein-based COVID vaccine licensed in the United States Nuvaxovid. Thank you for your time and attention. We would be happy to answer questions.
Thank you for a very clear presentation. So we have time for maybe 2 questions this time. So Dr. Berger.
Thank you for the presentation. I have a fairly quick question. If there was a different recommendation than FXG, what impact would that have on your development and delivery timelines?
So thank you for the question. As I mentioned, Sanofi is manufacturing XFG as the single global COVID vaccine for the 2026-27 season, ensuring patient choice of a protein-based vaccine at the beginning of the season. We are confident XFG is the right choice based on our data presented along with the current prevalence and diversification, and we will not be making another strain for this upcoming season.
Thank you.
Dr. Gantz.
I just wanted to put out there that while I understand that Sanofi seems to be prioritizing older adults and not prioritizing other cohorts, it doesn't have to be an either or. I feel like we can still protect vulnerable people in categories that we think are actually at high risk for disease. So for instance, children, and we've shown that at least in the very young, they still actually have disease. So I just wanted to put that out there because it felt like there was some diminution of the impact that these viruses have on other populations. Having said that, there is also some statements that were said that the 3.2.2 does not actually cause more severe disease. And so I had asked the question earlier, do we have data to suggest strain specificity in people who have infection, for people who are hospitalized with the different strains? Because it seemed to, you seem to suggest that maybe we actually do have that data. Maybe you could share that with us, that people who are hospitalized, for instance, or have severity of disease are not infected with a strain specificity that maybe is different than immunized people.
Yes, thank you, Dr. Gans. To address the first part of your question, I want to assure everyone that we did not mean to diminish the vulnerable younger population. We know that XFG is dominant in the United States, and as you mentioned, we believe that BA.3.2 is not associated with severe disease across cohorts. We can look further into the data that we have and bring it back after the break around, age cohorts and hospitalization data. We do know that XFG is the dominant variant in the United States in all age cohorts. And even during BA.3.2 surges in certain areas, such as Europe, we did not see an increase in hospitalization. So we can infer from that, something about severity linked to that variant. But we'll see what we can gather and bring it back after the break for sure.
Thank you.
Okay. Thank you. Dr. Omer, did you have a question or did you decide not to ask?
Yeah, I had a couple of questions, but since you indicated that you'll allow only 2 questions, I was number 3.
Yeah, do one of your 2 questions.
Maybe I can wait for for later conversation.
Okay, well, thank you. Okay, so thank you. And we will move on to the next presentation, which is from the FDA. And this presentation will be presented by Dr. Carol Weiss, who's the medical officer of the Division of Clinical and Toxicology Review at the FDA. And she's going to be talking about FDA considerations and recommendations for COVID-19 2026-27 formula.
Okay, so thank you very much. So this morning, the speakers presented some very important information and data that will help with the recommendations for the COVID-19 2026-2027 formula. And in this presentation, I want to give some regulatory considerations for some issues regarding vaccine strain selection, as well as give a high-level review of some of the data that's presented in order to set the stage for the committee's voting question and discussion. So next slide, please. So I want to give a little bit more background about some of these VRBPAC meetings to provide a little bit more context. So since the vaccines were first approved in 2020 or first authorized in 2021, there have been 6 VRBPAC meetings regarding COVID-19 vaccine formula updates. The first one was in April of 2022, and this involved an initial discussion about a framework for updating variant formulations. And that meeting followed really the first very large and deadly BA.1 Omicron wave. And shortly after that meeting in April, there was another meeting in June then that actually made recommendations for the very first update. And that update was for a bivalent Wuhan and BA.4/5 variant. And so that really represented the first time that there was going to be a variant update. And there was some hesitation about moving away from the prototype antigen, which had already demonstrated really good clinical efficacy. And it would be the first time that there would be an update. And so the recommendation was made for a bivalent at that time. And because the vaccines were only approved for a given dose, therefore the dose was split in half for each of those variants there. Additional data for more valency would require more safety and immunogenicity data. So the next meeting was held in January 2023, and there was an agreement that resulted in an agreement on a periodic assessment in spring for a potential variant antigen update in preparation for the winter respiratory season. And it was noted at the time that obviously these meetings could be adjusted as needed based on epidemiology and changing pathogenicity of potential variants. And that flexibility remains to this day. So the next meeting was held in June of 2023, and the dominant strains at the time included XBB.1.5 variants, and so that was the recommendation. And then again, in June the following year, the variants had evolved, and the JN1 lineage variants predominated, and the FDA determined a few days after the VRBPAC meeting that there was a preference for the KP2 variant if feasible. And last year in May, JN1 lineages again were predominant, and there was some drift, and the LP.8.1 was indicated as the preferred variant. So these decisions are really based, as you know, on the totality of the available evidence, including the antigenicity of current and emerging variants, vaccine effectiveness, and candidate vaccine immunogenicity. And again, the overarching objective of these meetings is to have an independent expert advice on potential variant formulation updates through an open and transparent process. Next slide, please. Okay, as you heard today, the evidence used to support these decisions includes the variant surveillance, current circulating, as well as potentially new variants and emerging variants. Variant antigenicity data. This typically involves looking at neutralization using primary infection sera after a single infection by a single variant. Of course, vaccine effectiveness data is important, and that usually comes in the form of real-world effectiveness studies. Post-vaccination serology studies look at responses after the existing vaccines. And then the candidate variant updated vaccine immunogenicity data is often of limited amount, but usually involves non-clinical data as well as sometimes human data. Next slide, please. So there are clearly inherent challenges in this vaccine strain selection process, and that involves issues of months-long manufacturing timelines, as well as manufacturer-specific constraints, which depend predominantly on the platform of the vaccine. This then means that we have to do variant forecasting many months ahead of time, and that, of course, is difficult because of the unpredictable variant evolution and seasonality. There's also, as we heard, declining surveillance and epidemiology data, so that also compromises some of the forecasting. And then we have to make these decisions based on the limited non-clinical and clinical data for the candidate vaccines that are available. And that's all in the background of actually, or on top of what we have is really heterogeneous population immunity from repeated natural infections and vaccinations. And that actually influences an individual's risk for disease, as well as an individual's response to vaccines. So next slide, please. So the vaccines are likely to confer the greatest benefit in those at risk for severe disease. And this graphic was shown previously and generated by the CDC, which highlights the highest at-risk groups. And those are the populations at both ends of the age spectrum. As you can see, children under 24 months have high rates of hospitalization, not so dissimilar from adults ages 50 to 74. But of course, it's much higher for adults older than 75. But what's important to note is that the background immunity in these populations is quite different. So children generally have lower amounts of accumulated immunity, but except for the infants, they are generally at lower risk of severe disease. The adult population, on the other hand, has substantial immunity, but it's often heterogeneous, and still those at highest risk are the oldest adults. And of course, there's the immunocompromised group of people who are at risk across all ages. So next slide, please. And just a few additional considerations. As has been noted, humoral immunity wanes even after multiple exposures, increasing susceptibility to reinfection and disease. Vaccines generally elicit the strongest responses to the matched variants, but cross-neutralization responses may also be generated against antigenically related variants. Neutralizing antibody titers are associated with protection, and they remain our best indicators for predicting vaccine potency, but the absolute protective thresholds are not known, and it's clear that there are other components of the immune response that also contribute to protection. Variant vaccines may differ in immunogenicity, and finally, we can make our selections really are dependent upon the availability of candidate updated vaccines. So next slide, please. So I'll just review some of the data highlights really to set the stage for the voting question. Next slide, please. So as you've heard from many speakers, the variant landscape currently is very complex, and actually it is quite different than it has been in prior years. So in the earlier years of the pandemic, virus evolution patterns were often marked by global sweeps of dominant variants, such as D614G, Delta, BA1, and JN1, with continuing diversification within those lineages as time goes on. As you've heard repeatedly this morning now, the situation is really different with this BA3.2 variant. Because it's been circulating really, or it's been identified for about 18 months ago, and it is different, and it consistently has been co-circulating with the dominant JN1 lineage variants across the globe. And interestingly, it seems to reach maybe in some countries 10 to 40% predominance, but it never displaces the JN1 variants. And the reasons for that are really not clear, but they've been mentioned earlier, potential fitness barriers or immune barriers. But the real unknown is whether it will acquire additional mutations to overcome those limitations. So as reported by the CDC in the US, BA3.2 still makes up a very small proportion of the total variants, but it has been increasing. Next slide, please. Okay, so these phylogenetic trees really highlight that genetic distance. And the figure on the left, as we can see, the BA3.2 is really clearly a saltation variant with many different mutations relative to the current circulating strains. And what I want to point out here is that BA3 would be greater genetic distance than the current LP.8.1 strain. And it is the genetic distances between other updates, XBB 1.5 to KP2, you can see are actually smaller. The tree on the right also highlights the point that BA3.2 really, derived from a much earlier Omicron variant and has just been evolving over the years and only became detected really in the last 18 months or so. But the genetic differences obviously don't tell the whole story. So we need to start looking at the antigenic differences. Next slide. And so this is yet another antigenic map. These are made using the neutralization data against the different variants. The sera that's used here is a specific sera generated in hamsters after a primary infection, a single infection. And these represent hamsters that have either seen BA322, NP1.1, XFG, or LP8.1, and JN1, as well as some of the earlier variants. And so this map is somewhat similar to those that have been shown by others. We can see that in the top left quadrant, the BA3.22 is really quite antigenically distinct. And we see in the lower right quadrant somewhat clustering of the JN1 lineages, with the more recent lineages do show some antigenic drift, at least with these sera, and good overlap with LP8.1.1 and XFG. Next slide, please. Okay, so the virus is evolving, they're antigenically different. So how have the updated vaccines performed? And we heard data today from the CDC and their analysis, both the 2024 and the 2025 COVID-19 vaccines did provide additional benefit against medically attended illness among children and adults, including the immunocompromised adults, and it was more robust against severe infection. The interim data for the current vaccine indicates additional protection as well against urgent care, emergency department, and hospitalizations. There's also supporting literature and I've only pulled out 3 here, coming out of Canada, Denmark, and England. So they're pretty consistent that there is still added benefit, at least for those at risk. Next slide, please. Okay, and just a recap of a lot of the immunogenicity data that you heard this morning from all the speakers. So for post-vaccination human sera, the LP8.1 mRNA vaccines elicited robust cross-neutralizing antibodies responses against antigenically similar JN1 lineage variants, including NB.1, 0.8.1. But as you heard, responses against the BA322 variant are significantly reduced compared to the JN1 lineage variants. We had the fortune to see what a candidate BA3.2.2 vaccine looks in a small clinical study, and I guess the lead time we had for the BA322 circulation allowed us to get some of that data. But the responses were lower than expected, with reduced cross-neutralization to JN1 lineage variants. Several groups noted that adults with prior multiple antigenic exposures do show low-level neutralizing antibodies responses against BA3.2.2, but we don't really understand the clinical significance of that, whether that would confer any benefit on another BA322 exposure or not. And in the non-clinical studies, both LP.8.1 and XFG vaccines elicit robust cross-neutralizing antibodies against antigenically similar JN1 lineage variants, including NP.1, 0.8.1, but with reduced cross-neutralization of BA3.2.2. BA3.2.2 vaccines did appear to elicit lower than expected homologous neutralization titers, but they were boosted with reduced cross-neutralization of JN1 lineage variants. Next slide. Okay, so in addition to working through all of the evidence, there are harmonization efforts for recommendations for the variant antigen updates for the COVID-19 vaccine. So the FDA does participate in technical working group meetings with the manufacturers regarding the available clinical and non-clinical data using current and candidate vaccines. And as well, we have discussions with international regulatory authorities regarding potential recommendations for the updates. Next slide, please. Okay, just a recap here. Current variant trends favor emerging JN1 lineage variants, such as NB.1, 0.8.1, while the persistence or potential dominance of divergent BA3.2.2 remains unclear. LP 8.1 and XFG-based vaccines elicit cross-neutralizing antibody responses against antigenically related JN1 variants, but titers are much lower against VA 3.2.2. And BA 3.2.2 based vaccines improve responses to BA 3.2.2, but may have lower intrinsic immunogenicity and definitely weaker responses against JN1 lineage variants. Next slide, please. So with that, we leave the committee with the voting question for the 2026-2027 formula of the COVID-19 vaccines in the U.S. Does the committee recommend JN1 lineage XFG variant as the preferred variant for an updated monovalent vaccine? The committee members will be asked to vote yes or no or abstain. And next question, next slide. And the discussion topic for the committee is please discuss circumstances that may warrant recommendation of a non-JN1 lineage variant, such as BA 3.2, for COVID-19 vaccine use in the U.S. And thank you. And I do want to acknowledge also Office of Vaccines Leadership and Management for contributions to these slides. So thank you.
Thank you, Dr. Weiss, for a very clear presentation. We have time for maybe one or two questions. Just to tell the committee, we break for lunch right around now, and then we have a hard return at 1 o'clock Eastern time for the open public hearing. So the questions have to be limited now as well. So Dr. Durbin?
Thank you for a really nice presentation, Dr. Weiss. My question is the FDA considering the regulatory pathway for a bivalent vaccine, given that there's sort of two second-generation vaccines that have come about since the previous bivalent, the 1283 Moderna and the Sanofi vaccine? Is there a framework for a pathway to licensure for a bivalent? Should the need arise sooner rather than later?
So there doesn't need to be a unique framework. The existing framework would apply to manufacturers that would want to come in with a bivalent vaccine. We would need to see immunogenicity and safety data in sufficient numbers.
Would you need half the dose though, as you did with?
Well, no. I mean, it's really up to what the data speaks for itself. So if data were brought in with varying doses, we would need to see the immunogenicity, no interference, and safety data.
Great, thank you.
So the current pathways exist. Thank you.
Dr. Gantz?
Thank you for that summary. I really appreciate it. I just wanted to point out a couple of things that I think are missing and maybe would be informative. As we've been mentioning since the beginning, it would be nice to see some testing of a bivalent, particularly when there is a strain we don't understand its impact clinically. There were some data that were shared that up to 60% actually in the younger age groups actually are with the BA 3.2, and it would be important to understand that. And then there's a lot of comments that this is increasing in the US, and we didn't get any population-specific data on that. Who is it increasing in? And I think that would be important. Lastly, we need the manufacturers also probably to provide challenge data so that we could actually understand the titers that are being presented to us. While most people will boost their titers after receiving an antigenic exposure, we don't understand that is particularly in these cross strains. So there was some data to suggest that there is slight boosting for the 3.2, but is that enough? We don't even understand that. So I think that there's several points that need to actually fulfill, some data points that we need fulfilled really in order to understand this picture fully. And lastly, the only thing I will say is we seem to be missing also additional safety data. In the past, we have had the CDC provide us with some of the surveillance systems that continue to be active for the COVID, which obviously continues to survey. And I think that would be nice data that we need. So I think those are all sort of missing from the conversation.
More epidemiology data, more data, would be helpful. So I don't have much to respond to that. But I do want to point out, I mean, the children are vulnerable because they're, for whatever their immune system is, but they're naive to both XFG and BA.322. And so unless we know that one is more severe than the other, and I don't think there's current data for that, I think that has to be realized that a mismatch either way is not great for those that are really naive in the youngest high-risk groups.
Okay, thank you. I just to add something to that response. I think there's data for use of a bivalent vaccine in preclinical trials, very limited, but I think there's some available. I don't know if the manufacturers have them have anything that they can or will present, but there's a little bit. And what I remember is it shows that when you have a bivalent vaccine, with half the dose, you get half the response. So that's something to put into the equation. But I don't want to speak for those data because they're not my data. Okay. Okay, Dr. Fuller Romney, did you want to say something before we adjourn for lunch?
Yes, so I just wanted to add some perspective with respect to some of the consideration we need to provide in the context of bivalent vaccine. For mRNA platforms, why the manufacturing process may be identical, but when you have to produce 2 mRNA sequences and blend them into a nanoparticle formulation, there may be challenges with respect to the stability of the co-formulation and making sure that both of them are patent. And to your earlier comment, now you're going to have to split the total dose between the two antigens, which may dilute the immune response to each of them. And in the case of recombinant vaccine, the manufacturing process will even be more complicated because now you're going to have to manufacture and purify and characterize 2 separate antigens. And so having to bring all of that together just becomes more complicated for protein recombinant vaccines.
Okay, thank you. So I think what we should do now is we will continue this discussion after lunch. So we will convene for lunch and return it'll be 1 o'clock Eastern time at the top of the hour. And then we have a open public hearing. And then after that, we will go into additional discussion. So with that, thank everybody. I want to thank everybody and thank the presenters from the companies and from the FDA for doing great jobs. So see you later. So I want to welcome everybody back to the VRBPAC meeting today. And what we're going to do now is have the open public hearing where we will hear from the wider community with various questions, comments, etc. So for this part of the meeting, I'm going to turn it over to Cicely to provide information.
Thank you, Dr. Perlman. We will now begin the open public hearing session. Both the FDA and the public believe in a transparent process for information gathering and decision making. To ensure such transparency at the open public hearing session of the advisory committee meeting, FDA believes it is important to understand the context of an individual's presentation. For this reason, FDA encourages you, the open public hearing speaker, to, at the beginning of your written or oral statement, to advise the committee of any financial relationship you may have with any of the COVID vaccine sponsors or their products. For example, this financial information may include a sponsor's payment of your travel, lodging, or other expenses in connection with your participation in the meeting. Likewise, FDA encourages you at the beginning of your statement to advise the committee if you do not have any such financial relationships. If you choose not to address this issue of financial relationships at the beginning of your statement, it will not preclude you from speaking. The FDA and the committee place great importance in the open public hearing process. The insights and comments provided can help the agency and the committee in their considerations of the issues before them. That said, in many instances and for many topics, there will be a variety of opinions. One of our goals for today is for the open public hearing to be conducted in a fair and open way, where every participant is listened to carefully and treated with dignity, courtesy, and respect. Therefore, please speak only when recognized by myself or the chairperson. We will now begin with open public hearing speaker number 1. Please unmute and introduce yourself. Please unmute.
Hi, no conflict of interest. My name is Paul Hennessy. I strongly encourage the committee to ensure that COVID vaccines remain universally acceptable without restrictive labeling that limits access to only high-risk groups. COVID continues to affect people across all age groups, health statuses, and long COVID remains a serious ongoing public health threat. Vaccines should be available free of cost, and people have the option to receive updated vaccines every 6 months, especially given the virus's rapid evolution and lack of predictable seasonality. I also encourage recommending manufacturers to continue targeting a monovalent JN1 lineage vaccine, preferably XFG 1.1 for mRNA and XFG for Novavax. XFG is fine for Novavax because it's more effective at reaching further to more variants. Current evidence suggests that JN1 descended variants remain antigenically similar to provide a broad protection, while BA 3.2 does not currently appear to warrant selection as a primary antigen target. To target BA 3.2 would be a failure, and to try the bivalent again would be even worse. In addition, the strain selection process should occur more frequently, at least twice per year, in alignment with the WHO schedule. COVID does not behave like a strictly seasonal virus. Waiting too long to update vaccines leaves the public behind the virus's evolution. Peter Marks desperately tried to align COVID with the flu, which resulted in more unnecessary cases. Strain selection should happen earlier in the spring, with the goal of making updated vaccines available before children return to school in the late summer. I also urge the committee to expand Nuvaxovid's indication to include pediatric use and extend its shelf life from 6 months to 9, consistent with other COVID vaccine products. It's unacceptable that we still don't have a protein-based option for kids, which would better protect against the severity you all discussed. Finally, I believe it's important for VRBPAC to publicly acknowledge the advantages of Nuvaxovid, which are increasingly clear. mRNA has failed to provide meaningful protection from transmission and long-term effects of COVID. It's not anti-vax to point out that a superior vaccine exists with Novavax while also pushing for next-gen nasal vaccines. The recent study from Mass General Brigham said 1 in 6 people who have had COVID developed long COVID. That is not the definition of a protective vaccine. Evidence suggests Novavax provides broader variant coverage, a stronger mucosal response, improved durability, higher quality antibody composition, and fewer side effects compared to existing options. There's also meaningful potential for an updated protein-based priming series for individuals previously vaccinated with mRNA. Acknowledging these benefits would help restore trust in public health institutions and better position us for the next phase of the pandemic, where the long-term effects of COVID continues to significantly impact millions of people. Thank you.
Thank you for your comments. We will move to speaker number 2.
Good afternoon. My name is Aaron Siri, and for any conflicts, see SiriLLP.com or AaronSiriOfficial.com. If you're interested in making an evidence-based and not belief-based decision regarding COVID-19 vaccines, please review the data and evidence in the letter we submitted to this committee. Don't ignore the tens of thousands of individuals that have contacted just our law firm regarding serious injuries from COVID-19 vaccine. Don't ignore the over 40,000 individuals seriously injured from these products that are members of just one group, React 19. Don't ignore the fact CDC fought us in court for over 2 years to hide from the public the data which showed that over 7% of the 10 million V-Safe users reported needing medical care after a COVID-19 vaccine, on average 2 to 3 times each, with over 70% of those medical encounters resulting in hospitalization, emergency room, or urgent care. Don't ignore the fact FDA fought for years to hide the data, which has been just recently released, showing that when FDA properly conducted empirical Bayesian analysis internally, it resulted in incredible safety signals that were hidden from the public. Don't ignore the fact that in the clinical trial for Pfizer's COVID-19 vaccine, there were 21 deaths in the vaccinated group and 17 deaths in the placebo group, meaning more in the vaccinated group during the same period of time. And I note the placebo group actually had slightly more people than the vaccinated group. Don't forget that those seriously injured by these products have been abandoned because pharma has been given complete immunity for their injuries under the PrEP Act, and the CICP has almost no funding to pay claims and is designed to deny compensation. To call the CICP a perverse mockery of justice and betrayal would be far too kind. 5 years after assuring the world these products are safe, they still need PrEP Act immunity for the harms they supposedly won't cause. Until this immunity is lifted and the harms actually accounted for, this committee should decline to recommend any further COVID-19 vaccines. But given the prior statements made by some members of this committee about these products, statements reflecting belief and not evidence-based views about them, it will no doubt be hard to objectively consider the data and evidence regarding these products. But please try. Thank you.
Thank you for your comments. We will now move to speaker number 3.
Good afternoon. Financial relationship. My name is Bert Neller, and I am the Legislative Director for the National Grange. For the past 159 years, the Grange has been the leading voice for rural Americans with over 1,400 local and state chapters across the country. We are a true grassroots organization focused on doing what it takes to support our communities and, when needed, to raise awareness of the needs of rural America to the state and federal level. I am grateful for the opportunity to speak in support of continued broad and equitable access to the most effective COVID vaccines available. The work of the committee to determine the appropriate formula of the updated committee recommendation for the vaccine is to protect Americans during the upcoming respiratory season. This is critical and very much appreciated by our members. While our roots are in agriculture, our membership has diversified and evolved over the years to include a wide range of professions, ages, and backgrounds. As our members have evolved, so have their needs. One of the rural America top needs today is access to quality, effective, and timely health care. The state of healthcare in rural America today is, quite frankly, abysmal. Local community hospitals are losing resources, forcing them to shut down critical departments such as maternity wards and intensive care units. It's becoming harder and harder to recruit new, talented medical providers to come to work in rural areas. And while telehealth can be a powerful tool, it remains unreliable for many Americans who still lack basic access to high-speed internet. When you don't have a doctor's office, clinic, or even a reasonable hospital within 30 miles or even an hour of your home, preventive care becomes that much more important. That's why the Grange has long been an advocate for access to vaccines. Now note that we sure leave our members an individual discretion as to the decision about whether they get vaccinated, but we strongly believe that effective vaccines need to be available and accessible. They need to be cost-effective, safe, and we know they're saving lives by preventing serious illness and the need for advanced care in parts of the country where that simply doesn't exist. For rural Americans, vaccines are especially critical across the lifespan, as men, women, and children living in rural areas have higher rates of many types of illnesses, from pneumonia and flu to obesity and certain types of cancer. The choice to vaccinate against COVID has often been based on how clear the understanding is of the guidance that is provided. We are grateful for this committee to continue your commitment to evaluate and determine which vaccines are the most safe and effective tools against serious illness. It is our hope that the updated version of the COVID vaccine be made available at the same time this year as the flu vaccine. This allows Americans to plan ahead and ensure that they make the time to travel to their nearest provider or pharmacy for their annual vaccines. Both options should be available. The National Grange stands ready to share this committee's recommendations on their updated COVID vaccine to ensure our communities have the knowledge they need to keep their families and neighbors healthy. As we continue to advocate for solutions to address the healthcare disparities that are plaguing rural America, we thank you for ensuring we have access to the best tools for prevention. We thank you for the opportunity to address and make our comments known to you today. Thank you.
Thank you for your comments, and we will move to speaker number 4.
Thank you. Can you hear me?
Yes.
My name is Don Ford. I have no conflicts of interest, though I am accepting applications. I have slides. Thank you. Next slide. So we're talking about variant selection. This is my 4th year presenting over variant selection, and the talk about BA.3.2 is a little disappointing to hear, to be completely frank. BA.3.2 is a fringe variant that it has demonstrated the ability to grow in multiple countries, but has never gone to a point where it become dominant. It is a concern. It is something we should keep our eye on. But we're framing everything from the perspective of the limitations of mRNA, not under the capabilities of what Nuvaxovid, now covered by Sanofi, is capable of doing. So I think that we should be really looking at changing our strategy overall of how we approach COVID vaccines, because we're definitely selling our minimum protection as maximum protection while ignoring the potential of maximum protection right now. Next slide. So this is kind of a long explanation that you can come back to review, explaining why it fights more variants, requires fewer updates, has fewer AE, activates a broader range of immune responses, has a better upper respiratory tract response, and more importantly, it creates persistent, non-transient protection that can easily be boosted on. Right now, we're dealing with focusing on a vaccine that has limited boosting potential for a year-round virus. We have a seasonal approach for something that is constantly affecting us. When we have 3 years in a row of waves, of summer waves, we can't look at this as this is going to hit us like the flu. It's not the flu. It's its own thing. And it's really important that we change our strategy right now to make that happen. Next slide. I've right now, more than anything, more important than anything going on, when the RFK and Co came in and asserted control over VRBPAC and ACIP, they put on limitations on pediatric Novavax expansion. Because keep in mind, Novavax is the same vaccine for all ages. one vaccine for everybody. And for some reason, we put these unnecessary limitations because of this group who is no longer present. They set a date for 2028 that does not need to exist right now. We need to go back and reevaluate and fast track this so that we can have a protein-based vaccine for all ages, because it's the same vaccine that someone can get at CVS right now they could be using to protect their children. Next shot. Another problem we're having right now, wastewater tracking. The CDC is about to cancel wastewater tracking for variant selection. And I know you see variant selection for vaccines. No, variant selection, keeping track of that the whole time, what variant's coming next, super important. The CDC is about to cancel that. I know you guys are not the CDC, you're the FDA, but this is where it starts. We have to come and do something about this. Next slide. I've talked about this before in previous presentations, but right now we have had summer waves. I put 2 years in a row in the presentation, but it's actually 3 years in a row we've had a summer wave. We need to change the timing of COVID vaccines to be closer to the school year release. We need COVID vaccines to come out in the summer, not in the fall. That's not working. So we need to have it come out in the summer to meet these waves, and that's something that we need to change not only at the federal level, but also the manufacturers have to get on board with this. It will actually probably lead to more vaccine sales, so keep that in mind. Next slide. I'm going to say this again. The people who just left, who were putting limitations on Novavax expansion to pediatric use, are gone. We don't have to look at these recently departed casting a shadow over everything we're trying to do. It's time to move forward and get some real protection for our children, because right now what we're doing is not working. Next slide. Just a side note, 2 days to create a presentation is not enough. I have included an additional slides to explain my background on why this vaccine is better and why we need to approach this differently, because what we need is a second vaccine approach, a second generation vaccine approach, which is a normal way to approach, just like they eradicated smallpox. That took 3 different vaccines. So, well, actually a lot more than 3 different generations of vaccines. So we need to do the same thing, and we need to handle this right. Next slide. If an update is required, it should be XFG. For mRNA, it should be XFG 1.1. They need a more specific variant, and that's just the way it's always been through all these presentations. XFG for Novavax should be fine. And we also need to keep in mind, when we think about BA.2.3, the one thing Sanofi is not selling in the product that they've recently acquired is that the increasing of antigenic breadth from multiple vaccines. They seem to not understand how the product fully works, but more vaccines increase the breadth of antibodies. So when you think about BA.3.2, getting an XFG vaccine or multiples of them will increase the breadth of antibodies to include BA.3.2. So should BA.3.2 become dominant or become a real threat, additional XFG vaccines is all we're going to need to meet that demand. But we should be considering Nuvaxovid as a second generation vaccine and then waiting for a third generation vaccine that will be some type of mucosal intranasal vaccine. Okay. Thank you.
Thank you. We will now move to speaker number 5. Please unmute.
I have a slide deck as well. Okay, good afternoon. My name is David Trident. I have no conflicts and no relevant financial relationships. Next slide, please. It's clear that our current COVID vaccination strategy leaves much to be desired. Last month, a study showed that a single booster dose does not meaningfully lower the incidence of long COVID. When the antigen match is not ideal, we've seen 6-month effectiveness data drop to 25% against emergency visits. At the same time, we continue to pay a price for the increased reactogenicity inherent to the mRNA vaccines. As Novavax authors point out in a recent literature review, These routine side effects drive parental hesitancy to get children vaccinated across diseases, which is a problem that extends well beyond the COVID pandemic. Next slide, please. Currently, we're seeing the lowest transmission of COVID since 2021, and this relative lull gives us a chance to correct course. We should be preferentially recommending Nuvaxovid and acknowledging its benefits, including the prospect of an optional new priming series for people previously vaccinated with mRNA. To facilitate that, the shelf life should be extended from 6 to 9 months, and importantly, the indication should be expanded to include pediatric use. We have robust data showing that Nuvaxovid is safe down to at least 2 years of age. If more immunogenicity data is requested, that should be accomplished through future post-marketing commitments, not by preventing vulnerable populations from accessing the vaccine until those studies can be completed. Next slide, please. Regardless of the details, the basics remain true. All COVID vaccines should remain accessible to everyone who wants one and be free of cost. Under the current framework that limits use to high-risk populations, an estimated 70% of Americans are still eligible, so it really only adds confusion and pointless barriers to access. Next slide, please. VRBPAC should continue to recommend a JN1 lineage vaccine, while leaving the specific strain selection more in the hands of the vaccine manufacturers. As we move into an era characterized by diversification within JN1 lineages and co-circulation of distinct evolutionary branches, it's more likely for different update strategies to be required across platforms. Within the current framework, however, I'm absolutely in favor of a recommendation to target the XFG variant. Next slide, please. Finally, CBER should consider convening the VRBPAC in a manner that reflects the reality of COVID-19 being a year-round virus instead of a seasonal one. At the least, VRBPAC should convene earlier in the season for strain selection, similar to the influenza selection, so updated vaccines can be released before return to school and before the annual summer wave of COVID transmission. Additionally, VRBPAC can meet on an as-needed basis only if a potential need to update arises. Otherwise, the current vaccines could just remain on the market so there are no summer gaps in availability in the first place. Thank you.
Thank you. Good afternoon. My name is Katrin Warner-Perez, and I serve as the Director of Health Programs at the Alliance for Aging Research. The Alliance receives sponsor support for non-branded vaccine education and older adult access. We thank the FDA leadership for convening this VRBPAC meeting and for the opportunity to provide these public comments. The FDA's advisory committees, including the VRBPAC, play an important role in the regulatory ecosystem, and today's open forum is just another step towards strengthening public overall confidence in the UFDA's regulatory decisions and knowledge that they're informed by rigorous analysis and diverse expert perspectives. We encourage the agency to continue leveraging these venues to support transparent scientific dialogue going forward. Last night, we submitted a sign-on letter on behalf of more than 30 organizations who urged the VRBPAC and the FDA to consider the following 2 requests. First, we ask that the committee provide manufacturers with an immediate recommendation regarding the 2026-2027 updated strain for COVID-19 vaccines for use in the United States so that production can begin without delay and so that vaccines are available ahead of the upcoming respiratory season. COVID-19 remains a leading cause of doctor visits, hospitalizations, and deaths caused by respiratory viruses in the United States. And as of May 9th, 2026, preliminary data from the 2025-2026 COVID-19 season in the U.S. indicate that COVID-19 infections were responsible for an estimated 780,000 to 2.3 million outpatient visits, over 120,000 hospitalizations, and over 13,000 deaths. This burden of COVID-19 deaths is shouldered disproportionately by Americans ages 65 and older and other high-risk groups. A recent study actually found that most of those who died from COVID at ages 65 and over were unlikely to have been close to death prior to infection, and 28 of whom were estimated to survive an additional 5 years had they not had the infection. While the number of people exposed to COVID-19 antigens has been increasing due to vaccinations and infections, the virus continues to evolve rapidly and is therefore becoming increasingly immune evasive. Because immunity wanes over time, there remains an urgent public health need for continued availability of safe and effective COVID-19 vaccines that can help boost individual and group immunity. Secondly, we ask the committee to continue to honor patient choice and promote uptake by facilitating continued availability of both mRNA-based and protein-based vaccines. While FDA-approved and authorized vaccines are roughly comparable in terms of safety and effectiveness, patients may either prefer one vaccine over another, especially considering the difference in technologies. And beyond issues of choice, supply chain stability is a practical and public health imperative. Relying on multiple vaccine manufacturers decreases the risk of a potential vaccine shortage should there be a future supply chain disruption. In addition, maintaining multiple production lines helps ensure that updated vaccines can be produced as necessary to address new virus variants. We urge the FDA to continue facilitating a resilient supply chain for COVID-19 vaccines. Vaccines offer the single best method for preventing infection, severe illness, and death from COVID-19 for all age groups. And while the benefits of vaccination in terms of protection against death are disproportionately realized by older Americans and other immunocompromised individuals, vaccines remain an important protective option for both adults and children to reduce acute morbidity from COVID-19, as well as long COVID and downstream complications such as sepsis and other life-threatening conditions. We encourage the VRBPAC and the FDA to echo these messages as much as possible today. Thank you.
Thank you for your comments. Dr. Perlman, I'll hand it back over to you to conclude the open public hearing.
Thank you, Cicely. And I want to thank the open public hearing speakers for concise and coherent contributions to our discussion. So with that, we're going to move back to the regular meeting. And for this, we're going to have a half hour or more for discussion with the FDA, the CDC, and the industry presenters. So with that, I'd like to ask the committee to raise their hands for any questions. The first question is from Dr. Rubin.
Yeah, I'd like to get back to Dr. Gann's opening question about bivalent vaccines. I just would like to hear what the thinking is on not necessarily a bivalent vaccine now, but what is the cost of doing bivalent vaccines, both in terms of production and in perhaps loss of efficacy because there's a decreased amount of each antigen in the mix. Thank you. And I know I didn't direct that to anybody, so I'm willing to hear from anyone's thoughts.
Hi, this is Kayvon Majared from Pfizer BioNTech. Dr. Rubin, thanks for that question. So I just want to clarify first, you're asking about what are the manufacturing considerations for bivalent vaccines, and then your second question was related to the immunogenicity of those vaccines?
Correct. The change in immunogenicity by both mixing them and having smaller amounts of each one.
Yeah, so what I can say first about the first question that you had, so we actually are able to supply a bivalent formula if that were to be the composition selected by the committee. However, it would be somewhat delayed compared to a monovalent vaccine and would require working closely with the FDA on review timelines to accommodate flexibility for an approval in time for a vaccine supply for the fall. With respect to the immunogenicity, so there's been quite a bit of data that was generated during the time when the original BA.4/5 and original plus BA.1 vaccines were licensed and used in the US and Europe respectively. There was a clinical study that we generated that showed that there was somewhat reduced responses, but not very much reduced responses. So if you could show slide 1, please. And this was with the BA1 vaccine. So for if you're looking from the left to the right, and I would draw your attention most to the first and the last groups. In the first one, that is the BA1 monovalent vaccine, and in the last group, that's the bivalent original plus BA1 vaccine. And so you have 30 micrograms in the monovalent and 30 micrograms in the bivalent of the BA1 plus 30 micrograms of the wild type. And you see they give very similar responses. So there doesn't seem to be much interference there. When you look at lower doses of the monovalent BA1, you also note that in the third group over to the right, that's a bivalent that has 15 micrograms of each, you get somewhat lower responses, but importantly, the geometric mean fold rises across all of these different groups are very robust and somewhat similar with one another. Recently, we've also generated data, preclinical data for bivalent formulas for the BA322 plus XFG and BA322 plus LP81. And we see that there, in an experience study where we looked at the geometric mean ratios of those titers, but first I can show you the geometric mean titers. If you pull up slide 3, we see that the overall responses elicited by the bivalent formulas noted in the 2 groups all the way to the right as compared to the monovalent formulas, which I previously showed in my presentation, those give very good breadth of response, the bivalent formulas, very similar between the BA322 plus LP81 or XFG vaccines, but somewhat lower potency in response as compared to the monovalent formulas, which is somewhat expected because these all have the same total dose. So in the bivalents, each antigen is at half dose. The last point that I'll make is, though, how does this actually translate into real-world effectiveness? And so there was real-world studies that were done during the period of bivalent use of the wild type or original vaccine plus BA.4/5, and it showed very robust effectiveness during a time of BA.4/5 and derivative BA.4/5 dominance. And so even bivalent vaccines, despite potentially a slightly lower immune response elicited, still generated robust effectiveness across a range of different clinical outcomes.
Thank you.
Okay. Thank you, Dr. Gans.
I see that Moderna came online. Did you want them to answer that same question, or shall I? Should I go back online?
Do you want to say something now?
Yeah, sure. I think similarly, Moderna has produced a bivalent vaccine in the 22-23 season. And if for now, the epidemiology, preclinical and clinical data do support the monovalent XFG formulation, if that were to change, we can certainly have the discussions with the regulators to enable the bivalent option. We do have very similar preclinical mouse data on the bivalent. And the conclusions are quite similar, that the XFG vaccine does provide, the JN1 the JN1 breadth, but also does raise the titers to a lesser degree to BA322 as well. So, we would be happy to continue the conversations on this.
Thank you very much.
Thank you. Dr. Gans?
Yeah, thank you so much for that. This is an important consideration, and I don't think anybody on this committee is saying at this point that the 3.2 is something that we're pushing for a bivalent, but I think the conversation is very important. And so thank you for providing those preclinical data, and it would be important to probably bring those forward. I did have some questions for the CDC, if the representatives or any of the manufacturers have continued safety data. I think that there is some misinformation in the public, and it would be nice actually to see those. I know that we get sort of report outs that things are similar in the current post-marketing phases as we saw previously, but I think it would be helpful to reiterate them. And then my question for the FDA, I don't know if I should come back to that, but I do think that we also have to really acknowledge the biphasic nature of this virus. The epidemiology is strong. It's continuing year to year. Last year, we asked for this meeting to be earlier, and again, we're in May. It feels like we should be evaluating the strains biphasically. So we should have a meeting probably in December to look at that epidemiology, and then probably come back in February or March to allow manufacturers time if there needs to be a change to get it in time for the. So I would like to push those two sort of themes forward if we could.
So would you like the safety question addressed now by the CDC?
That'd be great if they had that data.
Does anyone from the CDC want to answer the question?
Yes, I will answer, non-answer. So that data is collected by a different part of our agency called the Immunization Safety Office. I don't believe we have anybody online from that part of our organization. I have looked back at the past few years of agendas, and they haven't presented recently to this group in years past. They typically do present at our agency meetings, but unfortunately, we don't have anyone present today, and I apologize for that.
Okay, thank you. So Dr. El-Sali?
Thank you, Stan. My question is to the manufacturers and also to the TAG COVAC, Dr. Hagmans. There were no data presented today that point that XFG has any immunologic advantage over the LPA. It seems that the cross-reactivity, and even on a couple of, at least on one of the cartographic depiction, they were almost superimposed. So is the lift of changing to XFG worth the projected outcome that we are looking for?
Dr. Hagmans, are you still on the call?
Sorry, I'm here. Yeah, exactly. This was one of the points we took from the available evidence, indeed. So there is limited available evidence that there is superiority of the XFG compared to the LP81. So that was the point we took from the data available. And the data available from LP81, especially the human data and the serology cross-neutralization, showed strong responses. So in that respect, we were quite conservative in the idea keeping the LP81, but as I noted, that we consider that the other antigens, and especially the XFG and NB181, can be used as alternatives. So
I mean,
it's a bit
of course
other,
they can be used, but I mean, it was really hard to find the difference almost in those, looking at those data, but yeah.
I think there's limited evidence from human data, clinical data, using the XFG vaccine shows superiority over the whole board. I mean, this is more data also from other data we got. So that was our conclusion, yeah.
So do the other manufacturers like to address this too, Dr. Kalpitz?
Yes, thank you. Thank you for the question. During our presentation, we have shown that XFG variants are showing immune escape from JN1 in data using a mouse model, as well as sera from JN1 vaccinated humans. There's also data out there and shown by other presenters showing the XFG escape from LP81 vaccinations. You know, just to illustrate that XFG represents a significant antigenic evolution, we would like to share a slide here. On this slide, we have a graph presenting the average sequence distance between spike proteins of currently circulating COVID strains in the United States. In 2024, VRBPAC chose KP2 and JN1, shown in green, as seasonal variant selections, while the 2025 VRBPAC shifted to JN1 or LP8, shown in orange, effectively decreasing the mismatch between circulating strains and the vaccine strain. As time goes on, circulating variant sequences can start to drift away from the strain selected for the vaccine. As you can see by now, the LP81 variant is several amino acids away from strains currently in circulation, and XFG, shown in purple, most closely matches currently circulating strains. To us, this indicates that it is indeed time to update to a vaccine with the XFG variant, which is also the dominant variant in the United States and has many descendants in circulation.
Okay, thank you. Dr. Das?
Yes, thank you for the question. And so we'll also go back to some of the slides that we did present in the core presentation. So first, on the reduced cross-neutralization for both of the vaccines, mRNA 1273 and the next generation vaccine, mRNA 1283, we do see lower cross-neutralization titers for XFG compared to the vaccine-matched LP8. And then we don't have clinical data with an XFG vaccine, but the preclinical data from the mouse studies is quite consistent. And it shows that the XFG vaccine elicits the higher titers to XFG and as well as BA.322 compared to the LP81 vaccine. And again, right now it's XFG, but we do anticipate, as we've seen in the past, continued evolution. And while we can't predict exactly what that would be, it may be along this lineage. And so a closer match may ensure higher titers during the peak where the most vulnerable people need protection.
Well, I mean, after a titer of a few hundreds to the matched strain, I mean, the VE is already at 90%, if, in statistical analysis. So, and we're already in the thousands. So the difference between 1900 and 2035 is really not much of a difference. But
yeah, I mean, I think
And then the VE, sorry to interrupt, and the VE also, I mean, everyone was vaccinated with LP8 or whoever ended up getting the vaccine. And the VE with XFG being the predominant strain in the last 6 months here and abroad. And the VE is pretty much around the same estimate as before. So we have quasi, if you want, effectiveness data as well.
No, I think your point is very well taken, that it's really hard to match exactly with the vaccine with the circulating strain. And so it is about continuing to maximize the titers and anticipating that evolution will continue. And so we do feel that an XFG candidate may better match what is likely to circulate in the 26-27 fall season.
Okay. Dr. Majrad?
Yeah, thanks for your question, Dr. El-Sali, because you bring up some critical points. One point I wanted to stress is that XFG is a recombinant derivative of LP81. So it does represent an evolution of the lineage. But it is important to focus on the antigenic differences, not just the genetic differences. And it's also important to consider the totality of the evidence, as you cited. So you have a difficult task before you, but I think if the whole committee does, but it's important to consider the clinical data, the preclinical data, and the vaccine effectiveness data overall in informing that decision. And so the data that we have generated shows that XFG vaccine does elicit robust responses, but they are very similar to the responses elicited by the LP81 vaccine in their overall pattern of neutralization. against JN1 sublineages, and then also diminished against the BA.3.2.2. And then when you look at that in context of clinical data and the vaccine effectiveness across multiple studies, it shows very good responses compared to one another. The other part of this is that you have to look at the intersection of the immunology with the epidemiology. And currently, the epidemiology does show that XFG is the dominant variant still in the US, but it has contracted some. And so it's important not to focus on where the ball is, but where the ball is headed. And that's, of course, very difficult given that there's fewer and fewer sequences available. So it's a consideration, though, to take into account bringing together the epidemiology and the immunology in informing that decision.
Yeah, this is what you just ended with is precisely my concern, is that XFG is contracting. And the fact that BA.3 is in children is to me more concerning, because when a virus causes mild disease, it is often that school-age children are the engines of transmission. So, and it is growing. So anyway, I'll let others ask questions now.
Dr. Hogmans, did you want to say something about this before we move on to the other questions?
Yes. So indeed, I mean, the TAC-COVID really looks at the worldwide situation and geographical differences. So this also holds for the NB181, which dominates more in Asia and especially in Japan. So clearly it is stated by the vaccine manufacturers from Japan that they prefer the NB181 antigen because the NB81 is the dominant now. So this could be different for the US. So, but in that respect, the WHO TAC-COVID needs to look at a broader view, I would say. Thank you.
Thank you. Dr. Omar?
Yeah, so a couple of questions. First, with our Moderna colleagues, and then perhaps the others that also evaluated vaccine effectiveness could also chime in. Now, did you look at the duration of protection, and this, assuming, of course, that there is, as you look at longer-term vaccine effectiveness, as you move away from the time of vaccination, and I'm intentionally careful about using the term waning immunity because clinical protection is somewhat different than strict waning immunity. It may be driven by immunological factors, but there are other things as well. But nevertheless, in large database studies, did you look at that duration of protection kind of phenomena? And if yes, could you share those findings? The second thing is going back to V against, V for maternal immunization, any data around that that you could share?
All right. Are we? Yes, there we go. Okay, so I'll bring up our presentation. So this is the 3 effectiveness studies that we've done that were the matched cohort studies. And here you'll notice once I get the slides up that the duration is about, the median duration there is about 60 days of follow-up. We will look at additional cuts of these analysis, but right now this is the duration that we have. I think the CDC data that provided all of the breakdowns of the durations was quite informative, and we expect that we will be similar. And then the maternal immunization, we don't have any data specific for maternal immunization, but so I will turn that over to the CDC if they have those data.
Does anyone from the CDC want to address this question?
Yeah, thanks so much. So I was able to circle back with our colleagues. It looks like about 11, as of this year, about 11% of pregnant women had received COVID-19 vaccination. So uptake is quite low in that group, which again hampers our ability to measure maternal VE for protection among infants specifically. And it has been that way for the past couple of seasons. So I don't have any updated data I don't have any data from 24-25 as well. To your question around duration of protection, we did show some data where we looked at time since vaccination and VE by time since vaccination. We haven't seen any evidence of sort of waning protection yet, but I did make the point in the slide that we're still in sort of a relatively short time window since vaccination for the folks who have received vaccine, and we don't usually see it until about 6 months or so, which is about now when we'll start to probably see waning if it does occur.
Thank you.
Dr. Marjorie, did you want to answer that question too?
Yeah, can you hear me?
Yes.
Okay. Yeah, I just wanted to highlight that in our presentation, and if you pull up slide 1, we showed from our ID Drive platform, which is primarily among older adults, but measures against hospitalization, that we see a durable protection that maintains all the way out to 22 weeks. This is consistent with data that we've generated in the prior season as well. If you pull up slide 3 from a published report that we have from this past year, but for the JN1 vaccine in Europe. And there you see the overall effectiveness in the top row was about 76% for COVID hospitalization. And then going down, it's further and further out from vaccination. You can see it still maintains around that same level. It speaks to the point actually that Dr. Payne made earlier, that we tend to see more robust effectiveness against severe outcomes, and that the effectiveness sustains more so against those severe outcomes like hospitalization.
Okay. Thank you. So we can move to the next question. Dr. Patel.
Yeah, hi there. Thanks, Dr. Perlman. This is a question for Sanofi around implementation, and welcome the other manufacturers to answer if they'd like. So you mentioned that you are moving forward with your manufacturing of your protein subunit vaccine with the XFG strain. Are you able to share any timelines of when you expect that to be available for distribution? Do you think you might have it ready for distribution in the summertime? And again, welcome other manufacturers to respond as well.
Dr. Kolpitz, are you still on the line?
Hi, thank you. This is Tanya Kolpitz for Sanofi. I'll address the second question first, that our manufacturing process and timeline is a product of several components, including generation of early vaccines, testing, regulatory processes. So this year, we do anticipate having the XFG vaccine available for fall vaccination in line with the other manufacturers. To answer the first question around use and availability, we do know that Nuvaxovid was available across the US in the 25-26 season. That was a transition year between Novavax and Sanofi. We do anticipate availability in all 50 states and see substantially increased demand in the upcoming year. We also expect that improved consumer and vaccinator awareness will contribute to increased uptake. And our ambition is for all Americans to have the choice of a protein COVID-19 vaccine, again, which may contribute to increased vaccination coverage.
Thank you. Dr. Das?
Yes. I just wanted, I did want to confirm that Moderna vaccines, both of them, will be available upon approval and will be certainly available for the season like they have been in the previous years.
Dr. Majid?
Since Dr. Patel, you addressed this to all manufacturers as well, regardless of the formula composition that's selected, we're committed to having a regulatory package submitted soon after selection and doses available to meet patient needs upon regulatory approval.
Thank you. Dr. Gans?
Yeah, I just wanted to swing back and see if someone from the FDA could answer my question about timing of the meeting and just reflections on the ability to respond to the true epidemiology of the COVID. It's not like flu, and we seem to treat it like flu.
Dr. Weir, did you want to address that?
I can get started. Well, first of all, it's something we wrestle with pretty much every year. We've thought about it, and I wish I could tell you there was an easy answer to it, but there's probably not, at least not right now. It is true that one could push the selection earlier, but I think you have to be aware that there are trade-offs for doing that. The trade-offs are that you would have less data available to make a selection because of the clinical data from the current vaccines. You would, in some years in particular, the virus can change pretty fast, and the movement between, I think you mentioned December and the spring sometimes is actually significant, or can be. And then there is the other one, while it's probably not the major consideration, we do try to, when possible, align with other regulatory agencies in other parts of the world. So there are all these things that go into consideration. And again, I think we're open to considering it, thinking about it, and seeing what we can do. We haven't forgotten about it, but like I said, it's not necessarily an easy answer to just say, oh, we'll just move it back up 3 months or something. But we will continue to think about it and see what we can do. And I'll let others chime in from the FDA if they want to add anything to that. Over.
Yeah, so Dr. Weir, I had a question that I was going to ask after the other speakers, but since you're on the floor, or sort of on the floor there. So could you just briefly tell us what would need to be done to approve a bivalent vaccine? Are there extra regulatory procedures that would need to be followed?
Okay, so I can once again get started on this. First of all, the agency can deal with a bivalent. We've done it before and we can do it. I think one has to look at it at least in two different ways. One is vaccines with the current formulation of so much antigen. If one were to come in and want to change that vaccine with, say, double the amount of antigen, that would require a change to their manufacturer's licensure, which would almost invariably have to have not only immunogenicity data, but also safety data. If one wanted to stick with a bivalent vaccine that the FDA, this committee, recommended with the current amount of antigen, that can be done. But again, I think we have to wrestle with issues of imprinting and interference of the two components. I think we would have to be sure that each component generates a sufficient antibody response that we think is going to be immunogenic. I have to tell you, we would probably have to have more internal discussion about whether non-clinical data would be sufficient for that. It might not be. We might need clinical data to assure ourselves that the responses in a human population are sufficient with a bivalent vaccine with half doses. I think all of us recognize that there are serious limitations to the animal models of trying to mimic the human immunogenicity profile, what we experience in the human population. And so that's why I said we would have to have more discussion about the type of data needed for that. From a regulatory point of view, yes, it can be done, but I think we would have to be sure that we wanted to do it, that there was a need for it, and that we had sufficient data to assure ourselves and the public that what they were getting was going to be immunogenic and hopefully protective. I hope that helps, but others can add in. Over.
Thank you. I don't see other FDA hands. So Dr. Munoz, before you ask your question, can you introduce yourself since we had so much trouble in the beginning of the meeting?
Absolutely. Thank you so much. My name is Flor Munoz. I'm a pediatric infectious diseases physician at Baylor College of Medicine in Houston. And I work on vaccines for special populations, especially maternal immunization and vaccine safety and respiratory viruses. So thank you for the opportunity to ask a question as related to the topic that has been just addressed. I think we all have that sense of a need to be able to be more proactive with the vaccines as we see the changes of these strains over time, even though they seem to have slowed down and it's a different pattern as we have seen before based on the presentations shared as of now. So I think my two questions are related to, number one, our ability to continue to have the data that is necessary to characterize these strains in a timely manner. Globally, for sure, I appreciate the WHO guidance on that, and one sees the differences geographically that occur. But certainly, for making decisions in the U.S., this year-round circulation with changes that occur at a pattern that is not what we would have wanted to be, just winter seasonality is important. So I just wanted to see if CDC or others could comment on that ability, because I have to say I really appreciate the fact that all manufacturers have been able to really anticipate and prepare different types of vaccine constructs and test them with the information that is available. But I also see the differences in terms of the timeliness of having a vaccine out there and the challenges of having a bivalent vaccine. So my second question briefly is the ability, if the manufacturers could comment on the ability of quickly pivoting to, a newer vaccine, and what would be the type of data that would need to have so that, let's say we start with JN1 and one particular strain of that, but then this BA 3.2 starts coming up as a more prevalent one. Is there any data already of sequential vaccination with these based on what they've done so far? Or, again, what would be their ability to be able to produce another monovalent vaccine before this season occurs or this next year meeting occurs? Thank you.
Would the manufacturers like to respond? Dr. Das?
Sure. So thank you for the question, Dr. Munoz. And along with along with regulatory agencies and the CDC, we also do our own monitoring of the variant landscape, and we are continuously assessing whether we should produce vaccines at candidate vaccines at risk. We use that risk calculator that we showed in the main presentation, and we are committed, as we have been through this whole journey, to producing producing and making available new variant strains should like a replacement strain be identified. And we are confident, based on the experience that we've gathered to date and the exchanges that we've had, that we would be able to make that available in a timely fashion.
Dr. Marjorie?
Yeah, history set some guide here. Over the past 5 years, we've had to stay very responsive to the relevant epidemiology and not only be reactive to it, but be anticipatory towards it. We've been fortunate to be able to work very closely with the FDA and other regulatory authorities to ensure timely provision and timely review of data to allow for vaccines to meet patient needs according to the changing epidemiology. So this year, like any other year, would be no different. We had to do this in the context of BA1 and BA4-5 when things were moving very quickly with the emergence of Omicron lineages. And then again with the emergence of JN1 and KP2 concurrently, as different regulators focused on one or more of those lineages. And so here again, we would look forward to working very closely with the FDA to ensure that the data that is required for approval for whatever formula is selected is available and is able to be reviewed in a flexible timeline to ensure we meet the timelines of patient needs.
And Dr. Colpitz?
Yes, thank you. Our position is in line with the other manufacturers. Again, there are a number of variables and scenarios that contribute to the timing. Should there be a global public health emergency or similar situation, Sanofi would work as quickly as possible to ensure availability of a vaccine against any novel emerging strain. And we would also work with regulators to facilitate this acceleration. We continue to monitor surveillance and perform preclinical and clinical assays to evaluate, new vaccines and candidates as well, and supply that information to the agencies.
Thank you. So are there other questions from the panel? So I had a question that may have been answered already, so correct me if it has been. But in terms of pediatric vaccines from Sanofi, where exactly are we at with that? I think you've answered it, but I forgot the answer.
Yes, thank you for the question. Nuvaxovid is approved for children ages 12 and older with an underlying health condition that places them at higher risk of COVID-19. To allow access to younger children, Sanofi is committed to completing the pediatric study plan agreed with FDA, and we're engaging with FDA on these commitments.
And that would be for children as young as how many months or years?
We can't comment on that at this time, but we are working with the agency to ensure, access across vulnerable populations to our protein COVID vaccine.
Okay. Dr. Durbin?
This is just a general comment that we've heard throughout the meeting that surveillance is falling off, that we don't have the surveillance data that we've had and that we need. And I'm just wondering, I would love to hear from CDC, from FDA or manufacturers, is there something that this committee can do, make a recommendation to somehow highlight the importance of robust surveillance in terms of decision-making, identification of newer strains, et cetera, that may help increase the needed surveillance that we need, because what we don't know is very, very dangerous. And if there's a way to increase surveillance, I don't know if this committee can do that, but happy to make recommendations that might help.
I will say in the genomics space, you saw from our genomics tracker that we didn't have a modeled reporting period into the present tense in our last reporting period. That's been a continual problem over the past 2 years of less and less genomics data, and we've had to make several changes to our modeling, our reporting systems to sort of constantly adjust to make sure that we have enough statistical power to generate our models. And it is a constant sort of increasing problem with visibility in new emerging lineages and understanding what is circulating. So I hear you. We are definitely see the challenges and are doing our best to make sure you have the information you need to make these really critical decisions. But if you see a gap, any communication that you would like to do to highlight that gap, we are listening.
Thank you. Is this, do you think, a manpower or resource limiting scenario? Anything?
It's a multifaceted problem. It starts at the everything starts with a specimen, and it starts with testing practices. That pivot to at-home rapid antigen tests, which were really critical. But those specimens don't come into our surveillance systems. So it starts with testing practices, but it's sort of at every level. where there is a barrier, whether it be the establishment of enhanced surveillance networks, laboratory capacity, state capacity, our capacity here. Every barrier that we have, there's a bottleneck in the data, and at the end of all of those bottlenecks, there is less data.
Thank you very much. It's very helpful.
Dr. Osali.
Thank you. So this is a follow-up to what Dr. Thornburg just mentioned. I was reading that the wastewater genomic surveillance will be phased out in the first week of June. And I wonder, what are your thoughts on the potential impacts on the data presented or will be presented next year, for example?
We very much value the wastewater genomics surveillance program at CDC. That is done by a sister program here that we work very closely with. My understanding is that they will still be collecting the genomic data, but the analysis and the forward-facing, like that piece of it, will be phased out after June. So the data will be there, but the analysis and the interpretation will not be there. I believe that program is hoping to pivot in the future to another program, but we have relied on that data to sort of like a multi-pronged approach, just as a sanity check, has been really valuable for us as an agency. With the sequences that we're seeing in our clinical surveillance sort of match what we're seeing in wastewater. If people aren't, getting tested, we can say that, oh yeah, there really is BA.3.2 circulating in the community. It's been really incredibly valuable. So without that, we will have a little bit less visibility.
Okay, so the data will be collected. It's just that it will not be analyzed and be shared in real time with the public. But somehow eventually you will get
I believe the data will still be in public repositories and databases. So the raw data will still be available, but the dashboard will not be there.
Oh, okay. All right. Thank you. Well, that also, as a corollary to that, that makes aligning our meeting with sort of the international regulatory agencies that much more important, just so we have more data to go by.
Yes.
Okay, are there other questions? Well, if not, we're a few minutes early, but we can go on to the next section, which is the deliberations by the committee on the recommendations and voting. So does the committee want to do that? We could start, this would be about 15 minutes early. Is that the general consensus? Oh, Dr. Omar, did you have a question?
That was a thumbs up.
Oh, sorry. Okay, so let's do that if there's no disagreement. So, Cicely, what do we need to do next?
The committee, so everybody's finished with all their comments?
I think so.
Okay, so then we can go into the voting question if everybody's finished with their discussion.
Okay.
Okay, so what I'll do is I'll read the instructions for the panel. So the first question before the committee is a voting question. Give me 1 second. The first question before the committee is a voting question. The voting members will use the Zoom platform to submit their votes for the question. If you are not a voting member, you will be moved to a breakout room where while we conduct the vote, After Dr. Perlman reads the voting question into the record and all clarifying questions are complete, we will announce all voting we will announce voting to begin. A voting window will appear where you will submit your vote. There will be no discussion during the voting session. You should select the button in the window that corresponds to your vote, yes, no, or abstain. Please note that once you click the submit button, you will not be able to change your vote. I will announce that the vote is closed. Please note that there will be a momentary pause, maybe longer than momentary, as we tally the vote results and return non-voting members into the meeting room. Next, the vote results will be displayed on the screen. I will read the vote results and from the screen into the record. Thereafter, Dr. Perlman will go down the list and each voting member will state his or her name and how they voted into the record. Voting members should address the rationale for their vote. Dr. Perlman, would you please read the voting question into the record?
Okay, but then before, I will do that in a minute, but I would also like to suggest that even before we actually formally vote, that we have a more discussion of what our sense is after the day's meeting, because we've had a lot of questions, but we really haven't put our thoughts into a few sentences for each other. So I think going around the panel to see how people feel will be useful. But I will read the question first. For the 2026-2027 formula of COVID-19 vaccines in the U.S., does the committee recommend JN1 lineage XFG variant as the preferred variant for an updated monovalent vaccine? Please vote yes, no, or abstain. But as I said, before we actually vote, I'd like to hear what people are actually thinking at this point. So, Dr. Gans?
Thanks for that. I think it's been a great conversation, and I really appreciate all the data that has been brought forward from the FDA, CDC, and our manufacturing partners. I do think that I would be in support of actually having the variant be the XFG, because I do think that with the over time decrease in efficacy, the higher antibodies that we see with that, even backing into the other JN1 lineage strains, and potentially maybe slightly higher for the 3.2, although that's not as convincing, over time will be helpful. So I do think that I would support that. I also support it because of in the pediatric population who have not been exposed, it would be great to get them a variant-specific immunity. I did want to, so I support that, and I think that the data supports that, and I appreciated the conversations around whether it actually needs to be XFG, but I support that as the variant change, and I think it should be made. One thing that I think hasn't been raised, and I kept wanting to bring it up, and forgive me, I forgot, but I do think that when we're considering high-risk conditions for COVID and severe COVID, I do think that naive state is something that we haven't really, we've talked about it, we've kind of talked around it, we've talked about pediatrics being in that range, and obviously other people if they haven't been exposed, because we keep talking about how these are being tested in people who have conditions related to what we think are risk factors for having more severe disease. I think it's a little bit disingenuous to compare rates of a particular illness in children versus adults or other populations. Children aren't supposed to get sick. They're not supposed to have severe disease. And so there's also the populations are smaller. They have different exposure histories. So I appreciated the data of bringing other infectious diseases and actually looking at how they affect those populations that are at risk. This virus does put people who are naive to it, who haven't had these repetitive exposures so that the severity of disease and circulation So I think that conversation needs to continue and probably be in the forefront of what we're thinking about. So that is an additional reason why I support the XFG variant to be in this population. I do, however, and we can defer this to the, I guess, the conversation for the 3.2 and just in general, continuing our conversations of how these other variants, particularly because we have seen that in children, will maybe circulate after that. So those are my thoughts.
Okay, so I was just told that we should actually vote first and then have this discussion. So my error in doing that. So let's have a vote and then we will go back to this discussion.
Okay, so I guess we'll go back to this vote now. If everyone's clear on the question and there are no clarifying questions regarding the question at hand, then we will move into voting. Thank you. Voting is now closed. Dr. Perlman, if you would like to, we'll get the results displayed here in just a second. So we have 8 yeses, 0 noes, and 1 abstain. And Dr. Perlman, if you would like to go around the committee and have them discuss as you had previously indicated. Okay. Thank you.
So we'll start with Dr. Berger.
I voted in support of XFGs, the updated composition for the 2026-2027 formula. Sorry, you want us to explain now or just do the yes?
You can explain now, because I think once we finish this, we'll have a discussion about the BA 0.3.2 variant. So we should finish this discussion.
Okay. Similar to what Dr. Gans had said, the evidence that was presented to us today, XFG is the currently predominant circulating strain, though recognizing that it is starting to retract or become a little bit less over time. Seemed like the reactivity that we're getting with the current sera and other preclinical data seems to indicate that it actually has fairly good reactivity across the entirety of the JN1 lineage itself, as well as inducing reactivity against BA 3.2. Based on that and the ability to make sure that we've got both the mRNA and the protein based compositions out on the market, I've voted yes. Thank you.
Okay, thank you. So Dr. Munoz?
Yes, thank you. I voted yes. I believe that the data that has been presented today has consistently demonstrated the predominance of this strain, and also appreciated the data regarding the potential for the escape to the current immunogenicity that is available to the population, either through previous infection or vaccination. I think that this is timely. It seems that we are at a time where there could be more changes occurring with this particular strain. And the fact that the data that was presented with some of the vaccines that have been tested has demonstrated not just immunogenicity to this, but to similar JN1 strains, I think is very reassuring. So I believe that the strategy right now, as presented as well, regarding focusing on the high-risk groups, especially older adults, but adults in general with high-risk conditions, children with high-risk conditions, and also, I would say, emphasize the fact that for the very young, those under 6 months of age, indeed, we know that maternal vaccination can provide protection. And so that ideally, if we could also bring this message out regarding the new composition of the vaccine, the possibility of protection against these variants that are circulating, and the ability of maternal vaccination to protect the infants at that very young age is going to be critical as well. Thank you.
Yeah. Thank you. Dr. Durbin?
Thank you. I mean, agreeing with previous speakers based on the epidemiology data, knowing that that the XFG variant is the most common here in the United States for now, and looking at other JN1 variants that may be coming up, I still think that the BA variant is not as common in the US. I think we have to keep surveillance very, very vigilant, though, and I think that's a recommendation, probably not this question, but afterward, in terms of other things to consider. But for right now, it looks like it's the best match in terms of the strains that's circulating. The immunogenicity of the vaccines looks very good, and so I was very comfortable voting yes on the XFG variant. Thank you.
Thank you. Dr. Gans, do you have anything you want to add to what you said before?
No, thank you.
Okay, Dr. Omer?
Yeah, so I voted yes based on the data presented. specifically the breadth of protection, the data that was presented, also the trends in emergence and the epidemiology of the various strains. I did, I did get a bit of a pause. What gave me a bit of a pause was not aligning with international recommendations. It has implications. But there is a reason why we have, U.S. specific process and so on balance. I decided to go with a yes recommendation.
Okay, thank you. Dr. El-Sali?
I voted to abstain because no data were presented that show that the XFG variant is the preferred. It's acceptable, but it's not the preferred. It is, as I mentioned in an earlier comment, all the data shown indicate that it is interchangeable with the LP8, basically, in terms of the breadth of the response, the height of the response. And given that XFG, JN1, and its subvariants are what predominated for 2 years in terms of circulation, including high circulation in the 2 summers back-to-back, and vaccination back-to-back, we might be missing an opportunity to expand or the breadth of the response to, say, the NB and the BA3, et cetera, that are increasing, especially in younger, in children, who are the engines of transmission of respiratory viruses.
Okay, thank you. Dr. Patel?
Yes, hi. So I also voted yes, agree with everything that was just said by the other committee members. The couple of things that struck me were, number one, certainly the predominance of XFG. Number two was the immunogenicity data. It was nice to see that it was relatively consistent across the manufacturers. The third was Dr. Payne's presentation, where we're starting to maybe see a decrease in the durability of protection as that mismatch between the vaccine and the circulating strain or the infecting strain increases. I thought that was important data. And then I did appreciate Sanofi's comment that they will be planning to go forward with an XFG regardless of the decision here. And I think it's important to also have a protein subunit vaccine available on the market for people to choose from. Thanks.
Dr. Rubin?
I voted yes, and I have very little to add scientifically. I just wanted to salute the folks at the FDA and CDC, also the manufacturers, but particularly these groups where it's been somewhat difficult to do vaccine work, and their presentations were outstanding. Thank you.
Okay, so I think I'm the only one left, and I also voted yes for much of the same reasons. I think that the LP.8.1 vaccine would have been fine. That was what the WHO decided, but I was also swayed by the fact that Sanofi really has made the XFG. They don't have the LP.8.1. So given that the two are very similar, I think for the US, having the XFG variant is a good choice. So I voted yes. Okay, so if there's no further discussion, we'll move on to the second question, which is not a voting question, but it's a discussion question. So Cicely, could you put up, oh, here we go, perfect. This is what we're going to discuss. And we actually have been discussing this in various forms throughout the day. But the question is, please discuss circumstances that may warrant recommendation of a non-JN.1 lineage variant, for example, BA.3.2 for COVID-19 vaccine use in the US. Dr. Durbin?
I just want to come back to some points that Dr. Gans has made earlier that I think are very important as we discuss this case. And one is the frequency of meeting to discuss different variants so that we're not chasing them, but we actually are proactive and looking at data in real time to make these recommendations. We can't make a recommendation if we don't have data. And that's one of my great concerns, is the ability to get the data in real time and how we strengthen the surveillance that's going on and the ability to get the data that is needed to make these cases. So I think it goes beyond just the circumstances that may warrant recommendation, but how we actually get the data to recognize the circumstances to drive the recommendation. So I would recommend consideration of meeting more than once a year, and also strengthening recommendations to other agencies around the ability to perform high-level surveillance. Thank you.
Dr. Omer?
Yeah, I'll go one step further. I would say that in addition to considering more than one meeting or aligning the meeting with the periodicity, I would request or suggest a formal analysis, perhaps a mathematical modeling-based analysis or other analytical approach to look at the optimal timing of such decisions, as well as recommendations for when the vaccine should be timed in line with the periodicity. You know, understanding that some other committees, it goes into the purview of some of the other committees at the federal level, but I think sort of understanding some of those dynamics would inform some of the decisions or recommendations that are the purview of this committee, especially in the context of this broader question.
Okay, thank you, Dr. Gans.
So I highly support the comments that were already made. I mean, we've been talking about this in terms of being able to really get a handle on what these strains are doing is meeting more frequently. So I know that Dr. Weir had, cautioned us that the more frequently that we meet, the less data we may have. But actually, we have, most institutions are actually really collecting this data on a weekly. So I think we'd have enough is all I'm trying to say. I realize that we can probably make that inference as the limitations of the data allow. The other thing I would say is we really need to understand the disease manifestations of these, and we really need to understand strain-specific disease manifestations globally, but by age group. So it really took a lot to weed out the fact that the 3.2 was a more prevalent strain in other places, but we didn't see an increase in per se hospitalizations, but we don't know if the few hospitalizations that they were due to a 3.2, or does it just cause less severe disease? So overall, we need to understand disease manifestations of these strains to get us to a point that we would say we actually have a reason to try and protect people from this specific strain. And in addition, I think we need a better breakdown of the age group. So there was the very nice, I think it was the CDC that put, so the less than 6 months, then the greater than 6 months to 2 years, and then it had the different age groups for the adults, and you could see a tick up in adults 50 and above. So I think we start to ignore that because everyone is so fixated on the greater than 65 from some of the original data that the mortality rate is highest in those age groups, and maybe they have benefit more from the vaccine for that particular indication. But again, they have a higher mortality in general. So I think we need to take that in context. I would like to see some of the data presented with a better distribution of age groups. So I would love to see, instead of just 18 to 64, we should probably have 18 to 50 and then 50 to 64 and then greater than 65, or however those older groups. But we really need to do a better job, and we need to do a better job on the pediatric range and do a better job of the substrain variants within these groups, what kind of disease it causes. And I think that's the data that we would need to understand the threshold for putting, for recommending a vaccine that would then include the BA 3.2. It is on an uptick. Maybe the fact that it hadn't circulated in some populations and now has reached those populations, they're naive. Their immunity from either natural disease or vaccine is now in an area where they might become susceptible. I think these are all important. The other thing that we have to realize as part of this conversation is a lot of people test at home. So I think we really don't understand a lot of the epidemiology. And so there's probably a lot more disease, and that brings up the point of the wastewater, which helps us because we don't necessarily know that our data when we come into the institution is really representative of what's circulating.
Okay, thank you. Dr. Munoz?
Yes, I don't want to repeat what others have said already because I think we are thinking in the same line here, but I would just want to add that certainly this is not going to be a one-off situation. We would expect that we are going to be in this type of circumstance for the more time being with SARS-CoV-2 in terms of its ability to change and drift and potentially even at some point have substantial changes. So this question needs to be addressed every year. And I think that as we have heard, in addition to having a good epi data and genomic surveillance, certainly being able to understand the severity of the disease and the changes in immunogenicity to the various strains are going to be very critical. So I would just say we would be vulnerable, and we might be even more vulnerable without this surveillance systems in place, both in terms of the identification of the strains, which by now, just the way things are happening, again, with less testing and less ability for people to recognize that this is COVID versus something else, we are losing opportunities there. So somehow reinforcing that and making sure that we have a backup plan or another way to look at this, like the wastewater, for example. But in addition to that, in terms of the collaborative efforts, I would really also see how not just supporting the institutions that are currently doing the syndromic surveillance, the genomic surveillance, the disease surveillance and severity of disease, but also being able to collaborate with others that might have this information globally, because we see that there are trends and we do need to make decisions for the US. In this case, again, the stronger our systems are, the better we'll be in a position to make decisions for variants that are going to continue to emerge. Thank you.
Thank you. Dr. Rubin?
Of course, I agree with ongoing surveillance. Of course, we should be doing that. I do worry a little bit about the scheduled meetings, and I think yes, there are data being collected continuously, and they're being collected all over the place. But given the relatively small uptake of vaccines, we're often missing an important piece that we'd have to have in order to make any reasonable decisions, and that is an estimate of vaccine efficacy that we can believe, because already we're seeing these gigantic error bars in all the data that are being presented. And if we met more frequently on a scheduled basis, we'd be seeing larger error bars and we'd be looking at much more uncertain data. I wonder, right now the whole business is very qualitative. We look at a bunch of data and make a decision based on these qualitative data. There's no way around that. But I wonder if FDA and CDC could think about triggers which they could use, some quantitative triggers to say, okay, now is the time that we have to rethink and put together the data and put together a meeting. Because I think we will be spinning our wheels if we meet much more frequently.
Okay, thank you. Dr. El-Sali?
So if you don't mind me asking you, Stan, I want to answer directly the question that you're asking us. to comment on, which is discussing the circumstances that would warrant recommending a non-JN1, meaning what data will happen or will be had that will require us to make a different recommendation, or I'm just wondering sort of what the question specifically.
Yeah, I think that's part of the question. So the circumstances would be presumably informed by having more data. So I think it's all part of the same question. If you want to look at it more specifically, you might want to ask, what kind of increase in BA.3.2 do we need to see? What kind of changes would make us worry? Those are the kinds of things that would come to mind to me to make this so that we thinking about putting it in a vaccine. Because we certainly heard a lot that the BA.3.2 is not terribly immunogenic. We heard that it is spreading, but pretty inefficiently for something that's been around for 18 months. So I think that everybody referring to more data would let us know how are those processes changing, the kind of genetic changes that are occurring in BA.3.2. So far, I haven't seen much evidence that they're actually making things much worse, but we know that from watching Omicron as well as the earlier variants that changes can occur and become even more immunovasive. This one became more transmissible then that might make it a much bigger problem because it's just inefficient now.
I mean, it may be inefficient so far, but we were given data that in South Africa, it was efficiently transmitting, and also in Germany. So it seems quite fit to become a predominant strain. But it didn't happen yet. The trajectory is on the increase, but it is overall less than 5% in the general population, but higher in children. I would be concerned if BA.2 becomes starts sort of acquiring mutations and going up in frequency over the next few months, because our choice of XFG or LP8 internationally is quite robust for the JN1 lineage, but not for the BA3. The reverse could have, arguably the reverse would have been better, but that is speculation at this point. So these would be the circumstances that would make me want to actually revisit a JN1 lineage.
Yeah, I think the other thing that I may be wrong about this, but I think I've seen data that showed BA.3.2 is increasing in Germany and now is decreasing. So even in it's just not doing anything. It
increased. It became the predominant strain for 2 or 3 months and then began decreasing.
Yeah. I mean, it's not behaving like the Alpha Delta variants, where once they started, they just took over, especially the Delta variant. So that's what makes it a complicated question.
Yeah, but also it's antigenically distinct. And,
right. Yeah, just like those earlier variants. Yep. Dr. Berger?
Thanks. I'm going to answer similarly, but I wanted to take it out of the BA.3.2 context, because I think the question isn't specifically about BA.3.2. I think it's about how we would actually want to see us moving forward with anything that isn't a current JN1 lineage. I think I'd want to see some, the things that would kind of spike for me is when you're going to start displacing the predominant variants that are circulating. Greater transmissibility, greater hospitalization, greater severe outcomes that are coming up as part of this. I think those things are obviously going to spike a greater warrant at looking at changing the current recommendations. I would also want to see that there is a diminishment in cross-reactivity from the current vaccines that we have developed or the current antigens that are being used. To bring it back to 3.2 right now, the current data that we were presented today showed that the JN1 lineage antigens are still giving good cross-reactivity even for BA3.2. So if we got away from that kind of scenario, I think that's where we would start wanting to warrant looking at a change. And obviously, if there was some type of a shift to a bivalent vaccine, that would also give us another option for saying, hey, here's the idea of going with 2 potential different strains that we would want to actually see in the composition. But I mean, those are the things that I would be looking for. It's no different than I think when we started these conversations back when COVID was first circulating. What are the things we're looking for? We were looking for severity of disease outcomes, right? Hospitalization, ED resources being used, all of those things kind of coming up. So I could see a similar framework from how we actually were going then. I don't think it's changed significantly now. So thank you.
Thank you. Dr. El-Sally?
Yeah, I just wanted to follow up regarding the breadth of the response. And I did allude to that earlier in that, yes, we would like to see thousands, titers of newts in the thousands for all the strains, but we don't know exactly we don't know exactly the threshold of a protective titers, but we do know that once it's in the few hundreds, the VE is in the 90% plus against multi-moderate disease in the short term, granted. So I would be careful about making generalization pertaining to whether a particular vaccine has breadth or not based on this very high threshold like we saw earlier today.
Thank you. Dr. Gans?
I think the point, we keep circling around. We don't, and maybe, Hannah, maybe you have some data because you're saying like if it's in the hundreds, we know it's fine, but I'm not sure. I don't know. Anyway, I think that was the original, anyway, what I was going to say is I think we need challenge studies. Like we need to know what a protective titer is because given that the efficacy wanes over time, which we know is titer related, it does feel to me that the reason why these are protective in the early months after you have a vaccine is because your titers are high. They obviously go below a threshold. So with the fact that these titers are so high, it would seem the hundreds is not sufficient. I don't know, but without challenge data, I think that we actually don't know what's protective.
I agree with you pertaining to the magnitude of the titer being better for the long term, of course, because the decline will result in a higher titer, say at the end of the season. But the data that I'm mentioning is not to take away from the importance of obtaining high titers. It's just looking at the question of breadth in a slightly different way.
Okay, thank you. Are there any more comments? Okay, so I think we've reached the end of the meeting. It's quite early, so I hope if anyone has anything they want to say, feel free to say it. And if not, I will summarize what I think we've heard, and then I will turn the meeting over to Dr. Kaslow. So I think that in terms of the voting question, we mostly agreed that the XFG vaccine is a good target. There was certainly discussion of the BA.3.2 and also discussion of the LP 8.1 perhaps being pretty much equivalent. So maybe a little worse, maybe equivalent. But I think that was my general sense of the discussion on the first voting question. The non-voting question, I think, is a harder issue. We have a new virus. It's circulating at low levels. Some places it becomes dominant, then it doesn't become dominant. It's clearly not it's not a virus that's readily displacing the viruses that are already circulating, but it's something that's concerning. It's very immunoevasive with many mutations. These mutations all are, as far as we know, in fact, what we examine is a neutralizing antibody response. I think, as was mentioned earlier, there's other parts of the immune system too, whether it be the T cell response or the FC-related non-neutralizing antibody response that we have less of a handle on. But still, this virus is something that has not gone away and it's not increased. And because it's so immunoevasive, I think we were all thinking that we need good surveillance to see what's going on. We also need good biology to see if the changes that occur are going to impact transmissibility or virulence in any way. We really have no way of knowing that. Challenge studies were mentioned, but that's just one of several ways we could at least approach this issue if changes started becoming more dominant and concerning, because right now we don't really have a great way to assess whether the changes, each individual change is important or even a group of changes, what it's doing. So I think that's what I would conclude from our discussion. So does anyone have anything else they want to add to that? Okay, if not, I will turn the meeting back to either Cicely or Dr. Caslow, or both. Maybe Dr. Caslow.
Dr. Perlman. So today was the 5th VRBPAC convening to discuss and recommend an update to the formula of COVID-19 vaccines in the United States. And each of the prior meetings had their unique complexities that you were asked to consider. And this 192nd VRBPAC meeting was no exception. The SARS-CoV-2 epidemiology remains too unpredictable to routinize selection, not to mention the complexity of the antigenic maps with highly divergent variants, the impact of immune printing, and the diminishing availability of critical surveillance and epidemiology data. As Dr. Weir noted, FDA will continue to closely monitor for concerning changes in the SARS-CoV-2 epidemiology, and VRBPAC will be requested to convene as the need arises. Until then, let me start by thanking all the advisory committee members for your courageous public service and for another rich discussion on a complex and still evolving context for periodically updating COVID-19 vaccine formulas. Your proactive discussion on bivalent vaccines and the biphasic epidemiology are all well noted. So we are truly grateful for that input on this complicated topic of periodic COVID-19 vaccine formulation selection, as we all do our best to get the selection right, to get an optimal COVID-19 vaccine formula out in a timely manner, and to do so with the most confidence possible in those vaccines that are deployed despite the diminishing availability of critical surveillance and epidemiology data. And in that regard, I would like to highlight and immensely thank our CDC partners and their partners who are critical in optimizing the public health impact of the selected new formula, and to the TAG COVAC for their thoughtful analyses. Thank you to all of the presenters, our open public hearing participants, and a huge thank you to the CBER's and FDA's advisory committee staff and our AV staff who conducted yet another flawless VRBPAC meeting. I also want to thank the manufacturers who have generated a considerable amount of data at risk and readily shared that data with us in near real time. So as for next steps, FDA will provide regulatory advice shortly to manufacturers regarding the 2026-2027 formula, incorporating what we've heard today. And we anticipate manufacturers will move forward with both manufacturing and completing the data collection needed for FDA to take a regulatory action for timely availability of updated COVID-19 vaccines for the upcoming respiratory virus season. So I'll turn it back to you, Dr. Perlman, with a huge thank you for chairing today's convening.
Well, thank you. So with that, I'd like to thank the committee again. And I think the very last comments are from Cicely. You are responsible for adjourning the meeting. Is that correct?
Yes. Thank you, Dr. Kaslow, and thank you, Dr. Perlman. I'll now adjourn the meeting at 3:00 p.m. Thank you.